Okay.
So call this meeting to order. This is the North Lincoln County Hospital District monthly meeting. Couple of announcements ahead of time. This meeting, we're mostly taking care of business. It will not be a public meeting like it was at the special meeting a couple of weeks ago. We do have a couple of public members that have requested to be on the agenda. And we'll also be discussing a policy which we've just never had that much attendance, so we haven't had very many people at our public meetings. So we'll be talking about a policy for public comment when it is in meeting. That'll be a board discussion and board decision. We're also recording this meeting, so I'm requesting that anybody in the audience not record and put it on Facebook or any other media. We're recording the official copy, and it'll be available to anybody that wants to see it. It'll be on the website afterwards. This is kind of a trial this month for us to make sure our ITs have got it, our IT guys have got it right. So Rick, understand that that's what's happening. I am going to request that we kind of be a little more formal in our meetings than we have, and I've probably been the worst when I wasn't the chair. We need to, we're going to ask people that speak to the board to come to the podium and speak and direct their remarks to the chair. We're not going to have a lot of back and forth. If we want to choose for answers from staff, then we'll look at that, or attorneys or whoever. So things will be a little different going forward. As I've studied the Public Meetings Act and other statutes, I think we're headed in the right direction. Maybe we need to be a little less lax than maybe we have been in the past. And again, I was probably the biggest culprit, so I'm correcting my actions of behavior. So with that, we appreciate our public visitors attending, and hope that you enjoy the meeting. If you are on the agenda, then you'll get a chance to speak. If you are not, then you can certainly submit questions to the chair. I'll be glad to take those into consideration and get an answer for you. So we're down to item number 3, which is approval of our minutes of our last meeting, which was actually, we have 2 meetings to approve. The March regular meeting and the April 23rd special meeting. I'm open for a motion.
I make motion to approve.
Let's do them separately.
Make motion to approve March.
Okay.
Second.
We have a motion by Clint, second by Mindy, to approve the March 26, 2025 meeting minutes. Any discussion? All those in favor?
Aye.
Any opposed? Okay, now I'll entertain a motion on the special April 23rd meeting.
Make a motion to approve the April 23rd.
Motion by Mindy,
I'll second that.
Abby, second on the special meeting. Any questions, all changes from your board packet? All those in favor? Any opposed? Okay, Amber, note that those passed unanimously. We've had a chance to review our agenda. Any changes to that agenda? Any additions the board wants to make? If not, I would entertain a motion to approve the agenda. Let's see. We get all the things on it. Yes, report. Yep, we got everything we want on it, so that I wanted on it. Any additions? The agenda?
Yeah, the agenda.
So it's been moved to approve the agenda as presented.
Yeah.
Abby will second. Any discussion? All in favor?
Aye.
Any opposed? Okay. So we had a few questions, or at least I did. I don't know if anybody else did, about a Public Meetings Act and also public Records Act, I think, and I had attended some training beginning of this month, around the 6th, I think it was. I don't remember the exact date, with the state of Wyoming. And I passed that on to the board members, is recording a Zoom meeting. And hopefully you've had a chance to look at that and inform yourselves a little bit. We're gonna have some education by Brandon Taylor today. Oh, no, we're gonna do our ACO compliance first with Sadie, and then we'll come back to the Boards Act. I jumped up. Would you, Sadie, do your presentation? This is on, would you tell us what ACO means?
Yes, it's a accountable care organization. So for those of you who don't know me, I'm Sadie. I'm the Vice President of Quality and Patient Safety and the Compliance Officer. So this is our annual training that we do obviously annually. So I'll go ahead and just play the video, and then if you guys have any questions after, I'm happy to answer.
Hello, thank you for joining this compliance training for executives and board members. In this presentation, we will
Is
discuss
everybody able to hear
what is
back there?
ACO, why ACO compliance matters,
Would you turn it up?
ACO needs to know rules and regulations, and how to address instances of suspected noncompliance related to the ACO. First, what is an ACO? ACO stands for Accountable Care Organization. ACOs are groups of doctors, hospitals, and other healthcare providers who have come together to coordinate care for their Medicare patients. Your organization is participating as an ACO in the Medicare Shared Savings Program, or MSSP. An ACO is not a closed network, a type of health insurance, or a Medicare Advantage plan. All Medicare patient protections remain in place. Providers that participate in the ACO must follow additional ACO rules to ensure beneficiaries are aware of the decision they can make related to their healthcare. As an ACO participant, you have the opportunity to share any savings that result from providing high-quality coordinated care to your Medicare patients. In addition, your clinicians will benefit by certain scoring advantages that reveal higher Medicare payment adjustments in subsequent years. Your organization also gains access to CMS data, which can help you better manage the care of your patients and identify patients for care management. Finally, as an ACO participant, you'll have access to certain waivers related to patient incentives, financial arrangements, or other exceptions to Medicare rules. ACO compliance is important not only to protect you, but your organization and ACO partners. Non-compliance can result in the termination of your ACO from the Shared Savings Program, including that of other healthcare entities that have joined in the ACO with you. If your ACO has earned shared savings, non-compliance can mean that CMS will prevent you from sharing in those savings. Your organization can be subject to additional financial penalties, as well as termination from the ACO or being placed under a corrective action plan. As an executive decision maker, you could be subject to personal, criminal, or civil liabilities for egregious instances of non-compliance. Despite the fact that you are participating in an ACO, beneficiary inducements continue to be prohibited. In general, you cannot provide gifts or free services to Medicare patients. Any item of value that can be perceived as influencing healthcare choice is suspect under federal fraud and abuse laws. Never offer patients cash or cash equivalents or routine waivers of cost sharing. Some limited exceptions do exist around low-cost items or items related to medical care. If your organization does not have an ACO waiver program in place and you are interested, have your legal or compliance team reach out to the staff at CVS Accountable Care to talk about setting up incentive programs. As a participant in the ACO, you can market and promote yourself as improving quality of care for your Medicare patients. You can do this so long as those materials are not used in a discriminatory manner or for discriminatory purposes, as long as they are not advertising gifts or waivers, and they are not materially inaccurate or misleading. Note that CMS may request the submission of marketing materials at any time and ask that you stop using them. If you suspect non-compliance related to the ACO, you have an obligation to report that. You can report that via any of these three mechanisms. You can contact your organization's compliance officer. You can contact the ACO compliance team directly by emailing aco-compliance@signifyhealth.com, or you can report it anonymously through the ACO Anonymous Reporting Hotline, either by phone, book form, or email listed on this page. Thank you for listening. If you have any questions or concerns, please reach out to us at aco-compliance@signifyhealth.com. Thank you.
I'm gonna have some questions, but does anybody have any questions for Sadie and ACO? Gee, I'm the only one. So what are the financial incentives that we talked about? Could you explain those to remind me what those are?
Yeah, so the goal of being part of an ACO is to reduce the cost for patients, well, for Medicare patients. And by doing that, any of the shared costs that we have with the other hospitals and providers in the ACO, then we get part of that shared savings. And it just depends on, we submit metrics to the ACO on certain quality metrics. And so it depends on how well we do with those and how many patients we have that are attributed to us. And that's how much we get from it.
So an ACO is a combination of multiple hospitals?
Providers.
We're one of, providers.
Yeah.
Excuse me.
Yep.
Better word. Okay. Those financial, so the metrics, we have to submit something to the organization, I guess, that we're a part of. And that's a voluntary procedure for us to become a member of an ACO that we choose to.
Yep.
And we can choose which ACO.
Yeah.
We're tied to.
Yep.
Okay. And those finance, so our doctors have to submit, or you probably submit for our doctors, various reports saying what we did, and I'm sure you have a long line of questions. Is that the metrics that you're talking about?
Yeah. So like an example is breast cancer screening. So we look at how many patients have gotten their recommended breast cancer screening done. Fall risk is another metric we look at, smoking cessation, diabetes, depression.
Okay. So it all has to do with being healthier?
Yeah.
All of our patients healthier? Is
Yeah.
that?
Yeah.
What's incentivized?
The goal basically is to try and keep the patient, their costs low and out of the hospital.
So talk about marketing. How do we market for our ACO? How do I know that I'm getting any benefit?
Yeah, so all of our Medicare patients receive a notice of beneficiary explaining what the ACO is, and then they also get a follow-up at 180 days after they've received that.
Okay.
As far as marketing, I'm not sure exactly all that we do for marketing the ACO.
Okay.
Did you say that this was specific to Medicare, Medicaid, or the 65% population?
Just Medicare.
And
So
so your
direct your
report
comments to the board.
Sorry.
Chair, please.
question,
Yes, Abby.
now do I talk to Sadie or you?
You can direct it to her and me.
So my question is about, can you tell year over year how many, did we have to have like a nurse go and try to enroll people into this program? Is that something we're talking about doing?
That is a little bit different, but similar. That you're referring to is chronic care management.
Okay. Sometimes they kind of intermesh. It's the same
Yeah.
population of people.
It basically, we're trying, it's the members of the ACE or the patients in Medicare that have chronic conditions, and we're just trying to better help them manage that chronic care.
Yeah, I have a question too.
Yep.
I'm just curious, do you have any intelligence to know if other providers in our region are also members of an ACO? Is this somehow differentiating Star Valley Health?
That's a good question. I don't know for sure. It's definitely something I can get the answer to though.
Mr. Chair, I may have an answer to that.
Yes.
Of what we know in the state of Wyoming, Star Valley Health is an exception. There's not a lot of providers in the state of Wyoming that are voluntarily participating in an accountable care organization. Yeah, so it's a huge differentiator that we're being proactive in looking out for the Medicare beneficiaries.
Thank you. So you mentioned, one of the questions that I wrote down was, how does this help our organization? So we have financial incentives from, this is Medicare or CMS, I guess.
Mhm.
And how else does it help our organization? We have hopefully healthier patients that are Medicare age. Many of you haven't gotten there yet, but some of us have. Go ahead. Is there other benefits that?
Those are the two main ones. We really are just trying to keep our patients healthier. That's the whole goal of an ACO. Keep them out of the hospital, and more outpatient so that they can manage their care at home and not come to the hospital.
And so I think you've already answered this one. So it is connected to CMS. This is a program kind of sponsored by CMS, but it's a volunteer program, right?
Correct. Yep.
Does every hospital participate? I mean, there is no mandate by CMS like many things they mandate.
Yep. No,
They're not
no mandate.
mandating here. This is a voluntary effort to help patients.
Mhm.
Okay. Anybody else have any other questions?
Mr. Chair,
Abby,
Sadie,
please.
is it twofold? Do you have to validate that preventive care is happening, or just that they stay out of the system?
It's quite a bit. So we have attributed patients to us, Medicare patients, that basically, the ACO says, okay, these patients are your patients and you are responsible for them. So if they go to St. George and get care there, we're still responsible for that. So what they're really looking at is those metrics. But we work closely with our ACO on making sure that our patients get annual wellness visits, the chronic care management. So there's a lot within the ACO that we're doing to try and reach those numbers.
So in our quality meetings, like if the component is of diabetic training, then Troy has a piece of that and Corey might have something on preventive care appointments or something. It's multi department.
Yeah, including the hospital. If a patient gets admitted and they're discharged, we make sure that they have follow-up care with their primary care provider.
Other follow-up questions, anybody? Thank you, Sadie.
Yeah.
We'll now move on to having Brandon give us some guidance on the Public Meetings Act in the state of Wyoming. As I was saying, I went to some training a couple of weeks ago, and so it was kind of high on my thinking cap and thought we ought to have, say, maybe some board training. I sent you the video so you could listen to what, this was a presentation by the Attorney General's, or Wyoming Attorney General's office to board members and open to the public. So Brandon, if you would tell us what this act means and whether or not we're following the act.
You bet. Thank you, Mr. Chairman. So I have prepared hopefully just a handful of slides. Hopefully won't fall asleep. I'll do my best to make this more lively material than it is. But important nonetheless, obviously, and I think something that's important to discuss. Some of you participated in the new board member orientation that we did back in November when you were newly elected. So there will be some overlap in some of that discussion, but some of you are not as newly elected, and so maybe some of this will be good refreshers for you. as well. So, wrong direction. So, 4 different topics today. I'll make sure, in fact, I believe I have 30 minutes on the agenda. I'm gonna put a timer on the desk to keep me on track. Hopefully it's quicker than that. But we'll talk quickly about Robert's Rules of Order, the Wyoming Public Meetings Act, the Wyoming Public Records Act, and then your fiduciary duties as board members. As the chairman mentioned, kind of a more formal approach is being recommended by us as legal counsel and as from your chairman as well. So I wanted to just go over Robert's Rules of Order briefly. Robert's Rules of Order is 700 pages long. We're hopefully we'll be a little more brief than that in our discussion today. But obviously over the last month or two, there's not a secret that there's been increased attention and even maybe some scrutiny to the board and to the organization. Accordingly, as that occurs, I think there's a benefit to more closely adhering to Robert's Rules of Order to both protect you as board members, to protect the organization, and to keep these meetings more on task to the discussions at hand. So overall, in all the discussions today, the purpose is to emphasize the importance of transparency, accountability, and professionalism for each of you as trustees of the North Lincoln County Hospital District. So I believe my goal, which I think you share, is to empower you with tools for effective governance, right? We want you to be as effective as possible. So starting with Robert's Rules, again, the board has had less public involvement in the past, and as that increases, I think that the adherence to Robert's Rules of Order is encouraged and instructive. So Robert's Rules was initially developed in 1876 by Henry Martin Robert, a U.S. Army officer, and over time it has gotten thicker and thicker and more refined. But it's obviously used. It's recommended by the AHA. It's recommended to be used by most effective boards. So the key concepts of Robert's Rules and Orders, again, as the chairman has indicated, that all discussion goes through the chair. It can be a little cumbersome, and occasionally you may be used to having more informal discussions, but a closer adherence is certainly recommended. So one of the biggest challenges or adjustments, of course, will be that discussion to address the chair. So as brief discussion on that. So if Cole wanted to make a comment right now, you interrupt and just politely say, Mr. Chair, I have a question, or he would then recognize Cole as the speaker. Cole would direct his question to me. I would then readdress, Mr. Chairman, if I may answer Cole's question and then address my question back to Cole. So again, it's not going to be perfect overnight, but do encourage you to do so and to more closely follow those rules. So during the exchange, the board members, you may have questions and we can still have a discussion, but doing so allows us to stay on topic, and it also allows an opportunity for all members to speak and to have their questions answered. Spend less time motions. I think that's something that the board does effectively. I move that X, Y, and Z. It requires a second. You then have discussion. You then vote. Amendments can be made after a motion has been moved and seconded. A point of order can be used at any point. If you believe the chair has violated any of the rules, you call for a point of order and redirect the chair. Obviously, everything is made on a majority rule. Decisions are made by vote, not consensus. It's not enough just to decide collectively through discussion, but obviously a motion has to be made. Minority rights, everyone, regardless of how the vote comes down, has a right to be heard. So again, utilizing Robert's Rules of Order demonstrates professionalism and accountability. It provides a framework to reassure the stakeholders, the voters, and the patients, and everyone involved in the organization that the board is acting fairly and responsibly. It protects your integrity as the board, ensures that all trustees have an equal voice, regardless of your personality or position. It prevents dominant voices from taking over meetings or from discussing more than necessary. And it helps document your deliberations, decisions clearly in the minutes, right? When multiple board members are speaking at a time, it certainly makes Andrew's job more difficult. So a more orderly fashion certainly helps her to keep better minutes, which then of course helps the public be able to follow along with the decisions that you're making as well. So I'll pause briefly there. Any discussion or questions as to Robert's Rules of Order? Okay, hearing none, we'll move on. So now to get to the Wyoming Public Meetings Act. The purpose of the Wyoming Public Meetings Act is to ensure public access to government decision-making. So we'll start first talking about notice requirements. I know that's been a question, something that's been brought up by members of the community and by some board members. So what's required for you as a special district in Wyoming to provide notice to the public of your annual meeting? So you may be familiar with the towns. They're required to publish in the newspaper prior to every meeting that they're having a meeting. That is not required for you. All that is required under the Wyoming Public Meetings Act is that your regular meetings are set forth by resolution or set out in your bylaws, right? So if it says that the fourth Wednesday of every month is your meeting, that's all that's required under state law. However, above that, Andrea has published each year in January, she has published the full year schedule for, I believe, 3 weeks. Is that right? Now that's not required, but it's something that she's done. In an effort to look for different ways to make sure that the community can be more involved, it's now been placed on the website as well. So any member of the public can go to starvalleyhealth.org, go to the Board of Trustees, and your full calendar or your full schedule for the year is there. There's also been discussion of posting it to social media channels as well, to encourage public participation. Special meetings, they have to be notice has to be provided at least 8 hours prior to the start of that special meeting. And in the notice, it has to say what the purpose of the discussion will be, or the purpose of the special meeting, and then discussion would need to be limited to that topic if you were holding a special meeting. As for minutes, they do not have to be published in the newspaper. Again, you'll notice the towns do that. It's not required under Wyoming law for you to do, but of course, they're always available for public inspection. Anytime someone says, I want to see the minutes from your last meeting, under the Wyoming Public Records Act, which we'll talk about shortly, they're allowed to see those minutes. Now, I had a brief discussion with the AG's office who had presented the training that the chairman referred to earlier today. He recommends that you do publish them somewhere to your website. It certainly could be placed, online at the same place that your the notice for the meetings for the rest of the year. You could also have a link there that at least some, the last few months, last 3 months or 6 months or whatever makes sense, could be published there for members of the public to see and to review. Action cannot be taken by email. Meetings can be held over Zoom or similar technology so long as the public can monitor simultaneously, right? So the issue with trying to conduct or make a decision over email is the public would be excluded from those communications. But if you were to hold a Zoom meeting where you all participated virtually, that's fine, so long as that link to that meeting was published and provided in a place where the public could also access and monitor the discussions that you're having.
So, question?
Yes.
So with that in mind, on the Zoom meetings and that, as I understood it, we could also provide a location. Not everybody has internet.
Sure.
That people could come and watch the Zoom meeting. Would that qualify, or do you need to do both, or?
Yeah,
the other?
certainly you could take that approach. I believe that's how the county does it. The county doesn't provide the link for someone to watch in their pajamas at home, but they do provide for locations for you to participate in person, right? So if they hold their commission meetings in Kimmer, they live stream or Zoom the meeting to the courthouse in Afton. So if you want to participate in a meeting of the commission, you can go to that location. So you could certainly take that approach as well, where if the board was a hybrid, some of you were in person, some of you were online, or you're all online, you could still broadcast it into this room, and members of the public could come and monitor the meeting in that way as well.
Commission, I have a question.
Abby,
It feels like it correlates with, we're recording this meeting. Are we going to have a discussion as to how available that's going to be to staff and community? Is it something we're going to discuss?
yes,
Then I'll wait.
I believe that. Public, yes, public recording meetings, yes, it is on the agenda.
We'll discuss how it's disseminated in that. I'll withhold the question.
Sure, no problem. And just as a point, it would be public information that could be accessed by request. So if it's created and you have it, it is a public record, and any member of the public could request a copy of it and receive it. Now, if you want to publish, or, post it on your website so it's downloadable or accessible at any point, that's obviously your prerogative as well. But it would be a public record, and it would be accessible under the Public Records Act, which we'll get into a little bit as well. So subsequent meetings, this was one of the topics that they talked about, that the AG talked about in his training, about something that you may not think about, but would also be inappropriate or would make you subject to the Open Meetings Act. Would, if the chairman were to meet with Cole and Abby and talk about, whatever topic that he was trying to get your opinion on, you deliberated, you talked about it together. He then took those discussions and then went and had a similar meeting with Clint and Jeff and said, when I talked with Cole and Abby, this is what they wanted to do. This is what I'm thinking. What are you thinking? And then he goes and meets with Mindy separately. You now essentially have had a meeting, because you talked about the same thing, you deliberated about the same thing, and you've now invoked the Public Meetings Act, because although you did it separately, you deliberated and you came to a decision outside of a public meeting.
So is that the key, is making decisions?
Correct. You could certainly, certainly, especially with the staff, right? If Dan were to have three of you in a meeting and discuss and present something to you, he certainly could present the same thing to another group of three people. You just can't make a decision or deliberate or come to a conclusion on what action you're going to take, and then come to the, a board meeting, rubber stamp it, and have no deliberation in front of the public, right? So that's the concern. If you can obviously have a discussion about the same item separately, but if you're deliberating and you're coming to a conclusion and a decision, and then you're doing the same thing with other board members, you've essentially held a meeting, and that decision, is null and void, actually, because you didn't properly notice it. If that makes sense.
Abby?
Permission to address Brandon?
Yes.
So an email, because it's something that somebody can request, what if something is discussed, no decisions are made, but something's discussed with all of the board members? It worries me that looks like a quorum and that we're having a meeting that's not been advertised to people. I just wanted some.
Sure, yeah, we can go back to that discussion item. So our recommendation is that you do not conduct any business by email. Now, if the staff sends out an email to all of you, that's okay. That's not a discussion. That's providing you with information to prepare for this meeting or a public meeting. But basically, the opinion of the AG's office was to avoid any sort of discussion collectively as a board where all of you are on the email thread.
So you can share comments and decisions and information, but again, it's the making a decision by email, because there's no way possible we can send an email to everybody in the public.
Right, but I think that's exactly right. But the other concern, right, is if the chairman were to send an email to you all and you responded back to everyone and said, thanks, I got it, that's not a problem. But if you responded and said, I was reviewing, this contract or this decision or this report, and I really think that we need to address X, Y, or Z, that's when you now have an issue, because you're now discussing and deliberating about an issue with a quorum in place. You're just doing it over email. So really, in fact, the AG's office suggested that when the staff send an email to the whole board for meeting materials, now you use Onboard, so it kind of does this automatically. The AG's office suggested if Scott were to send an email to all of you, that Scott blind copy all of you on the email so that one of you can't reply all to everyone and then cause, a potential issue. So really the suggestion is that just to not hold any discussions over email or exchange.
A group email or a group text message other than saying thanks.
Correct, yeah. Now, that doesn't mean you couldn't email Cole directly and get his opinion on it, right? That's not a quorum. But the problem is then again, if you take what Cole said and you then email it to Jeff and then you take it and email it to Mark, now you create a quorum, right? But if you just are emailing someone directly and say, what are your thoughts on this? You haven't invoked a quorum. Just like if you ran into Jeff and said, hey, what do you think about this?
Thank you.
Okay. And then we've also, of course, we've been through in the past executive sessions. There's 12 specific.
Before you go on, Brandon, you missed subcommittee meetings.
Sure. Just
Would you comment on those?
you bet. So obviously you have subcommittee meetings and subcommittees that you're all members of. I think that the thought is again that you of course will continue to have robust discussions in those meetings. You'll be able to have more robust discussion about specifics, and then those meetings, the minutes are of course taken and then provided to the rest of the board. And those meeting minutes are public record, right? So although a member of the public is not invited to attend those subcommittee meetings, they could request and review your minutes because those would be a public document. So I just mentioned that again, you'll continue to obviously have those subcommittee meetings, which may be a little less formal and a little less closely adhered to Robert's rules. But again, that information is still accessible to the public. And again, all of this is done in an effort to be transparent and open with the public and the decisions that you're making.
Thanks.
And then again, finally, executive sessions, we've talked about that at length in the past. And there's only 12 items that you can go into an executive session for. Most recently or most applicable personnel litigation and potentially the purchase of real estate. So again, everything you do as a board, every decision that you make is open to the public. No action can be taken unless it's at a noticed meeting. And if you do take action at a meeting that's not open to the public, then any of those actions are null and void. Not voidable, meaning if someone complained, it would become void. It's null and void if you were to make a decision outside of the public meeting. So again, streaming the meetings online and having open meetings in general shows the community that the board has nothing to hide and decisions are always made in public. There were comments at the previous meeting with concerns about the airplane, and when they were addressed, the comment was, well, you should have made the public more aware of that, right? Having those discussions in an open meeting, having those meetings accessible to the public allows them to see that, had they been in attendance at the multiple meetings that you discussed the plane, they would have known that it was accessible and that how you came to that decision was an open. And so again, these efforts to put the meeting minutes online, to put the meeting schedule online, to live stream the meeting so that members of the public can attend, only sheds more light on the decisions that you make and the deliberative nature that this board has always exhibited to come to those conclusions that you do. So, these extra steps will just increase public engagement and knowledge to the decisions that you're making. So the public, but I think this is a good time to mention that the public has a right to monitor your every meeting, right? They have a right to be here and to hear what you have to say, but that does not necessarily mean that they have a right to speak at your meeting, right? And so we'll talk more about that as well, that it's a meeting in public. It's not a public meeting for everyone and anyone who wants to discuss. But of course, they always have a right to be here and hear the decisions and the deliberations that you make. So Again, transparency isn't just a legal requirement, it's a core value of public service. Boards that embrace the Public Meetings Act signal to the public that they are serious about their ethics, their accountability, and their public engagement. So I'll pause there before I go to the Public Records Act for any questions.
But I don't think you hit executive sessions as much as you were going to, maybe?
That was all I had to say. I mean, you move into an executive session on a motion. You state in that motion what the purpose for which you're going into executive session. And then, of course, any discussions held in executive session are done, are limited to that reason that you stated that you're going into, and no action, of course, can be taken during an executive session either. You come out and, of course, make any applicable decision.
Well, actually, we actually don't even make a motion
To adjourn this.
to adjourn
Correct.
an executive session because there's no motions made. And so can we have multiple reasons in an executive
Absolutely.
session, or can you only have one of the 12 at a time?
You can have multiple, you just need to make sure that that's disclosed in the motion, right? So I move to move into executive session for the purpose of discussing personnel and litigation, or personnel and legal issues, or personnel and or purchase of real estate. Just needs to be included in the motion, and then anything that's included in that motion can be discussed.
Abby?
I don't know who this question's to, whoever can answer it. But my question is, like, let's take the plane because that example was brought up. If they didn't have to ask for money, then the plane wouldn't have been discussed as a public meeting. How do we decide what things are discussed publicly and what just happens with the administrative team? Normal functioning things are not. Do you know what I'm saying? I can articulate.
I'll
it
answer
different.
that. So we have some key duties. This is part of something I was going to talk about. As a board, we approve the annual operating budget
Mhm.
and the annual capital budget and the strategic plan.
Yes,
And typically, within those three areas, we give authority to our CEO and his staff and administration and providers to accomplish the things that have been set out in the strategic plan.
follow-up question. The plane seemed to have fallen out of that because it wasn't planned for far enough in advance, and so then it became public discussion. But if that hadn't been the case, it would have been decided not in the public.
I don't know when you came on the board and we talked about the plane. I was at least a half a dozen meetings, subcommittee meetings and board meetings when we asked questions, and I thought we thoroughly vetted
Yeah,
the
We did,
plane.
but did they have to bring that up? I guess is my question.
Did, who have to bring it up?
Admin.
Did
It's
they
not a
have
que-
to?
It's not a
Yes.
question about the plane.
Yeah, it was, it would have either been in our capital expenditure budget discussion.
Yeah.
Or if it was not in an approved capital expenditure budget, they would have to come so that we can amend our capital expenditure budget. Does that make sense?
It answers the
So
question.
it does have to come to us.
Yeah.
One time or another, every expense, I don't know, and I'm already taking some of my comments, but in the end, guys, the board is responsible for everything our staff and administration does. Because we've approved the budgets, both the operating and the capital budgets. As long as they're functioning within those, there should be no, I mean, there's always going to be questions, but we've given them authority to function within those budgets. If they are doing something outside of what we've approved in those budgets, then they have to come and request the board permission to add maybe a capital item for an MRI machine or something, or a new ambulance, if it wasn't already discussed. Does that make sense?
It
And our,
does make
and our
sense.
capital budgets are usually fairly, line item. They go through, they start with a big wish list and gets narrowed down. By the time it gets to the board, it's a reasonable list typically. And, prior to that, the ones I've seen are not always reasonable. There are a wish list. And we have to look and see, what do we have the money to spend on and what's the most important thing? Is it the roof? Is it a new piece of equipment? That's where it is. The operating budget would talk about providers or staff. Do we want or need more staff? That's where we approve all those expenditures, all those wages that go out and benefits or approved by us. We're the ones that start that. Does that make sense?
Yeah.
It may not make sense, but you understand what
I
I'm
mean,
saying, I guess.
I speak English, it makes sense, yes.
Okay,
I guess my follow-up to it is when decisions are made and we're like, that feels like left field, then you're saying it should have been something we felt like we were part of the discussion on.
yeah, and if the board does not feel like they're part of the discussion, I think most of the board has been here long enough to know some of my concerns in previous board meetings, but we didn't have enough time to discuss things. And we shouldn't condense it. And so if you're feeling like that we don't have enough time to discuss, I'm willing to be here late to discuss things, but not every time. I go to bed very
I'm not
early.
pointing out any flaws in the agenda, I'm just
No.
clarifying.
And what I'm trying to say is, yes, I hope that the board that's the public square discussion that is so important with boards and public meetings, is that we hear from things, especially from the board members. You have questions of staff, of anybody, we can get, if we don't have the answers, and as I recall on the plane, we had to go back a couple of times and say, you need to check out a few things. We had some questions. And so I feel like we vet all of those decisions very, very well. Now, the public isn't always here, and so afterwards they hear about it, and they don't always come to a board member or to a member of staff and get the facts. They make up stories that are kind of interesting to read when I know the facts. And so I would hope the public, part of the process, I think, is the public needs to ask questions, and they ought to get their questions answered. There's nothing, we're not hiding anything under the bushel here. It's all open. And so, yeah, but I think they have a duty to go after the facts if they don't have them. That's probably more my opinion than anything else.
And so to that point, as far as the public involvement, we'll be discussing later in the agenda, a proposed public comment policy that will set forth the proper procedure for members of the public to come and make comments to the board. It's very common practice on boards to require that, and so that you as board members can come prepared to hear what they have to say, that the staff can prepare relevant documentation to go along with it. So, moving quickly through to the Wyoming Public Records Act. Of course, this ensures public access to governmental records. My strong urge to each of you, as we've talked about previously, is to use your official Star Valley Health email for all correspondence regarding your duties as Board of Trustees. Use of personal devices and personal email can subject your personal devices and personal email to public review and scrutiny. Certainly not to mention potential exposure if there was litigation or in that realm as well. But under the Wyoming Public Records Act, most of the communications, if not all, with few exceptions that you make, are subject to disclosure. So strongly urge and recommend you to use your Star Valley Health email address.
Mr. Chairman, I have a question about that.
Jeff.
With regards to contact information like that, is there any guidance that you would give for us as board members? So say a member of the community reaches out to me expressing concerns. Is it advisable to capture those as concerns and raise them in a board meeting for discussion and public record, or and when is it better to just say, thank you, but I'm not going to engage in a private conversation over issues like this? Where does that?
Sure. Yeah, it's a great question. I think that obviously you as board members are accessible to the public, and if members of the public are, reach out to you and have a concern that they want to address, I think it's probably, and we'll get to some of this as we finish up, as far as your fiduciary duty and your responsibilities. But I think that it's something you probably need to make a judgment call on. Is it a concern or something that's going to uh, that is a criticism of the organization that may not be most appropriate to have a discussion here? Is it something that could be addressed internally and get resolved? Right, so I think that it's something that you probably have to make somewhat of a judgment call as a board member that says, geez, this is something that, I've had multiple people tell me that the process is broken in this way. And so, certainly that generalized process would make sense to have a discussion in this meeting. If someone were to come to you with a concern about a provider or about an employee or staff member, that would not be appropriate for this setting, right? That would be a personnel discussion that would either need to be held in an executive session or again, maybe potentially addressed with the right member of staff to handle that. So does that answer your
No,
question?
it does, and this is perhaps no longer a question, it's more just maybe an observation, because I'm new to all of this and thrust into it in an environment where there's been a lot of public attention now. And I'm just sensitive to the idea that my observation is there are about as many ideas on how to solve some of the problems that is going through right now, and opportunities, because I think there are those too, as there are people in Star Valley. And so I think you have, I'm perhaps overly sensitive about what communications I engage in, because I don't want to give anybody any misunderstandings that where it's an opinion of Jeff England versus speaking on behalf of the board or the hospital.
Right.
And leading anybody along, or perhaps even in some respects, contributing to rumors in the community as a worst case. And so I feel like at a personal commitment, I want to raise those as perhaps questions to the board. So it's a matter of public record and we get that, and then turn people to the record.
Sure. Yeah, absolutely.
But there's no requirement necessarily on that. That's more just perhaps a personal approach.
Right.
Okay.
A question on that and then a follow-up comment. Should those comments come to us on our Star Valley Health email or our personal email?
Preferably to your Star Valley Health email. Of course, I understand that that's difficult to make everyone do that, right? So, I mean, if you wanted to respond and say, please direct the same question to my Star Valley Health email, that's probably absolute best practice. Do I understand that not all of you are going to do that every time that someone reaches out to you? I understand that. Something I think that is, if you receive an email to your personal email address and you respond from that, I think it's prudent to copy your Star Valley Health email to that and then shift the discussion, if there is continued discussion, to that email address, right? And remove your personal email address. If that way, if there was an instance where someone says, well, I want your personal email address. No, I have a standard practice that when I receive an email to my personal email that has to do with Star Valley Health, I reply and I CC my Star Valley Health email address, and then I continue discussions that way. So I think that that's the most prudent path forward. But I also understand that people have your personal cell phone numbers and your personal email addresses, and they may send you a message to those.
And I believe board, Andrew approached each of you on how you want to be contacted, and we're going to be putting that on the website. You want to address that, Andrew, while we're at
For
this?
right now, only your Star Valley Health email.
Correct. It would be Star Valley Health email. Some may have their personal cell phone numbers there though, if they choose to.
Right now, just
Oh, you're just saying there is no phone number.
at this time.
It's just email. Okay,
And it's on your particular.
okay. Well, and we'll probably be discussing that a little bit more. One of the comments I had on your comment, Jeff, was one of the things I think we need to understand is that when Jeff is asked a question, he can't act for the board, nor can I act for the board as a sole member of the board unless we have taken an action. Once the board has taken an action by proper motion and vote, then we all are ready to support that particular motion and vote. So When I'm speaking in the public, it's Marlo Sherman.
Yep.
It's not even the board chair or representing the board. If we've made a decision, and that will be in the minutes of the meeting, then you can share that as this is the board's position on that particular topic. And I think that's important for our board to understand that. We do not speak for the board individually. It's collectively. Or the hospital. That's correct.
So my time has expired, so I will just briefly go through this and then conclude. There's a designated records person for the hospital by resolution, which we'll address this later in the meeting as well. We've indicated that Andrew will serve in that role as the designated records person, also known as the custodian. Just so you know, when people make public records requests, we have 7 days to respond to them to acknowledge that they've made the request. Then we have 30 days to provide the requested documentation to them. The fees must be formalized and they must be reasonable associated with producing those requests. We'll be updating those fees later in the meeting as well by resolution. And so just quickly finishing with the fiduciary duty discussion that you all kind of at different times touched on. So what does that mean, right? Fiduciary duty. We talked about that. It means that you have a responsibility to act in the best interest of the organization, in this case, the hospital, not yourself, right? So your duty, now that you've been elected to this board, is to act in the best interest of Star Valley Health. So you're trusted to make decisions that help the hospital and the people it serves, putting the hospital's needs first, even if you don't personally agree, and requiring you to be careful, honest, fair, and prepared in everything that you do as a board member. So I recognize, and this is to the chairman's comments, you wear multiple hats as individuals sitting on this board, right? You wear a hat as a patient, for most of you, I would assume. You wear a hat as a community member. You wear a hat as a family member of an employee or a family member of a patient, right? So you have lots of hats, but you also have that trustee hat, right? And so when a member of the community approaches you with a concern about the hospital, they may be a community member, they may be a family member, they may be, a patient and an employee, or any combination of those, which we have lots of in this small community that we live in. But they're approaching you and you have your trustee hat on. And when you have that trustee hat on, anything that you say, even though you don't have the authority to speak on behalf of the board or behalf of the organization, it may be interpreted as on behalf of the board or the organization, right? And so you need to use extreme caution when engaging in those discussions. Now, I'm not saying, again, that if a member of the community comes to you and says, hey, I have a concern with what's going on at the hospital, that you can't talk to them about that. Of course, you can talk to them and you have a duty to talk to them and to have a discussion with them about what their concerns are. But you need to recognize that they see you as you are a trustee, but they may interpret that as a decision or a thought of the collective board, which it's not, obviously. So you also need to be cautious too, because of that fiduciary duty, right? So that duty is to put the hospital above yourself. You may share the same concern with them. You may share some of the same thoughts, but you should not criticize the organization in which you have a fiduciary duty to protect, right? And so you need to be cautious in the discussions that you have with those members of the public, because you cannot undermine the organization that you have the fiduciary duty to represent. So if you recall quickly, again, to finish up, you have within your fiduciary duty, you have the duty of loyalty, the duty of care, and the duty of obedience. Duty of loyalty, always act in the best interest of the organization, not personal or external interests. Avoid conflicts of interest. We've talked about that before. And this is one of the things that I wanted to discuss as well. Support the collective decisions of the board, even if you personally voted against them, right? So let's say the board has been a motion to make a decision, whatever that decision is. It's been seconded, you've had ample discussion, the chairs run a great meeting, everyone's had an opportunity to discuss, and the board votes 4-3 to approve the decision that was before you. That decision is now the decision of the hospital. And that decision is determined that it was in the best interest of the hospital. So even if you are one of the 3 members of the board that voted against that decision, you now have a fiduciary affirmative obligation to support the decision that the other 4 board members made. Because the board collectively has decided that decision was in the best interest of the organization. So if you publicly were to criticize that decision or undermine that decision, you have breached your fiduciary duty to support the organization. Even though you made it known that you didn't agree with it, even though you didn't vote for it, the opportunity for you to express that dissent and to vote that dissent happened in this meeting when it was moved, seconded, and voted on. Now that it's passed and it is the policy and the decision of the hospital district, your opportunity to criticize that decision has passed, and doing so would violate your duty of loyalty to the organization that you're elected to represent.
Ask to clarify.
Jeff asked one, you bet.
When you say criticize in public, I imagine that means like you wouldn't go out and do a social media post that says, just so you all know, I said different.
Right.
Does that also include one-on-one conversations? Like, let's say my friend calls me up and says, it feels like I still, as a fiduciary, would have the responsibility to still represent that we had a discussion, the board voted in this direction, and we're moving forward with this and refrain from personal.
Right. I mean, it's public record that you voted no, right? So you could say, well, I did vote against the decision, but it passed, and this is what we're doing, right? And now you have the duty you can share, these were the concerns I had.
Yeah.
This is why I voted no, but this is the collective decision of the board, and this is what we're doing, and this is why. And now you have a duty to make sure that it's a positive, or that you agree with, or not that you agree, but that you support the decision that the board has made. Again, publicly undermining.
Hang on. Abby, you have a question?
Sorry.
I just want to ask a clarifying question. Is it possible that it's an elected representative by the public that we have a fiduciary duty to them over the
No.
hospital?
No, your duty is to the hospital and the organization. Now, you still represent those people, and you may say, I've talked with all these people, and this is why I'm voting no.
Okay.
And that can be part of the reason why you voted no.
Okay.
But at the end of the day, if the decision is approved,
Fair.
now your duty has always been to the organization, but you can't, rally the troops and say, I'm your board member and I'm the voice of the people and this is what I did and I'm gonna, no, that would be inappropriate, right? You need to support the decision that the organization made. Now, again, you can vote your conscience and you can vote according to the people that you represent, but at the end of the day, when the board makes a decision, that's the decision. And you have a duty to support that decision. Obviously, again, publicly undermining the board decisions can erode trust and damage the district's credibility. Next, your duty of care. You make informed decisions by reviewing materials, asking questions, and understanding the issues. Support the administration in implementing board-approved policies and strategies. And again, this requires you to come prepared to these meetings, right? That you've reviewed the materials, especially if discussions have been had on the subcommittee that you're not a member of. You have a duty to review those minutes and to review that information so that you can come prepared to discuss it. And again, duty of care and loyalty and obedience does not mean that you can't bring up concerns. It doesn't mean that you have to blindly accept every decision that's made. You have a duty to do your due diligence, right? And that's that duty of care, that affirmative duty to review materials, to ask questions of Dan and the administration to make sure that you understand what's going on. So finally, duty of obedience. You have to follow the hospital's district mission, bylaws, and applicable laws, uphold board policies and decisions once they're made, and understand that individual board members have no authority outside of board meetings or official actions. The board's role is oversight, not day-to-day management. Once the board sets directives and approves plans, it's the administration's job to execute those plans. So publicly supporting the leadership team is essential for organizational stability. If performance concerns exist, they should be addressed through formal evaluation processes, not informal or public criticisms. Right? Again, this is not to say that you can't disagree with them, but do so in a way that supports the organization. Unified leadership builds trust. Disagreements are healthy during deliberation, but once a vote is taken, unity is required. Supporting board decisions and administration helps maintain morale, reduce confusion, and ensure consistency. So that's what I have for you today. Again, I think we'll have some additional discussions as we look at the public comment
Any other
policy
questions for Brandon?
and resolution.
I have one final loaded question. Has our board ever violated either of these acts that you know of?
I'm not aware of any willful or wanton violations of either of these. Now, can we say that it hasn't accidentally happened or unintentionally happened? I assume that it probably has, but I'm not aware of this board ever willfully violating any of these.
Do you want to add something to that, Dan?
Well, technical violations probably occur with every organization over time. But I don't think I've ever seen any kind of a violation that created harm or caused significant concern, or that even led to anything that needed to be remedied or redone or what have you. So no, I think in my experience, this board compared to the many other boards I've represented over my career, you are one of the most, if not the most compliant board that I've ever worked with. So I think you can give yourself very high marks.
Mr. Chairman?
Yep.
I think it's also worth pointing out, as one who's been called out to not talk about something in an executive session before, I'm really thankful, inadvertently, I want to point out, I've been really grateful for both Dale, and Brandon to be in attendance in those meetings and to help make sure that we're not doing anything unintentionally as well. So I appreciate your support that way.
Okay, moving on in our agenda. We have 3 public comments, one from Kenzie Mathis, did I say it right? And is she here?
Yeah.
Would you step to the podium and state your name and where you live, where you're from, and tell us what you want us to know.
Yes, I am Kenzie Mathis. I live in Smoot. I'm born and raised here. I'm from here. I am going to address a few things regarding EMS. It's trying to make it just a small 5-minute thing. I'm sorry, I'm so nervous with public speaking, but I at least know Clint and Dan, so.
Not me.
I will read what I have here. Good afternoon. My name is Kenzie Mathis. I'm a former dispatcher and a past EMT with Alpine EMS and a deeply concerned resident of this valley. I worked dispatch for 8 years. I've taken the 911 calls. I've stayed on the line during CPR, trauma scenes, and medical emergencies, sometimes for over half an hour, waiting for help to arrive. I've also responded as an EMT where every second mattered. I know exactly what's at stake when EMS is delayed. Today, EMS staffing has been slashed to just 13 medics and 3 supervisors for the entire valley. Same EMS has been reduced to a floating supervisor and a seasonal EMT or someone working overtime. Let me be clear, that is not a staffed crew. It is not a solution. It is patchwork. It is not compliant with the contract this community was promised. The EMS asset transfer agreement signed by Star Valley Health, the town of Thane, Star Valley Ranch, and Alpine EMS committed to 1, a good faith effort to maintain at least 1 EMT and 1 paramedic in Thane. 2, a functional operational base in or near Thane for at least 5 years. And 3, that EMS equipment transferred from Thane would continue to primarily serve Thane. None of these promises are being meaningfully met. A few summer shifts filled by seasonal workers or overtime volunteers do not fulfill a long-term consistent staffing requirement. That is not a good faith effort. That is a placeholder. And this is happening while call volumes continue to explode. Call numbers for EMS in 2020 were 564 calls, 2021, 766 calls, 2022, 941 calls, 2023, 1,000 calls, 2024, 1,138 calls, and 2025 is already outpacing last year, and it's only May. I've spoken with people involved. Out of respect, I won't quote them directly, but the concerns I've seen are consistent. Morale is low. Some former medics are suffering from stress-related health issues, and when they speak up, they're ignored or worse. I've heard that at least 7 medics have left or been laid off in recent months. That's not a staffing adjustment, that's a crisis. Let me remind you what medics actually do. They are the first hands on a failing heart. They kneel in shattered glass and snowbanks to save lives. They push medications that can either save a life or stop a heartbeat, and they make that decision in seconds. They deliver babies, treat overdoses, climb into wrecked vehicles, and hold the phone to a dying man's ear so his family can say goodbye. And they do this for modest pay, sacrificing holidays, sleep, and mental health because someone needs help. There's one call I'll never forget, dispatching. A 2-vehicle crash. EMS and fire were on scene. Over the radio came the words, "We'll be in the highway clearing human debris." That phrase shattered me. It revealed the raw, brutal reality our responders carry with them, and yet they still show up for the next call, maybe to help someone's grandmother off the floor. Last summer gives us a preview of what we will consistently see this summer. A plane crashed into the Palisades, tying up resources. At one point, 5 ambulances were out on separate calls. A paramedic had to care for a patient in the back while a firefighter drove. A fire call went unanswered because every ambulance was already out. Someone might say, well, it was just a fire call, but EMS goes to fire calls for a reason, to protect and treat our firefighters. Their lives matter too, and that day they were left without medical support. This was a much fuller staffed crew. Some argue that days like that are rare, but EMS is not built for the average day. It's built for the worst day. You don't cancel snowplow contracts just because it didn't snow last week. You have them for the storm. EMS is the same. Hoping we can manage it isn't a plan, it's a gamble. And when you gamble with EMS, you gamble with people's lives. And no, I'm not saying to drop the contract. That this is not about blaming our medics either. They are extraordinary. I'm speaking out for them. If this continues, burnout will rise, delays will increase, and our community will suffer. We are asking Star Valley Health Board of Directors and the towns that signed this agreement to, 1, publicly clarify whether SVH is complying with the EMS asset transfer agreement, 2, restore full EMS staffing and thing, and 3, create a public forum to address these issues transparently and honestly. And finally, I'm asking you to change the culture. EMS professionals deserve to be respected, supported, and heard. When they raise concerns, they should not be dismissed. When they're suffering from stress, they should not be ignored. We shouldn't be putting our hand on their shoulder and saying, well, if this place gives you health problems, you may as well leave. We cannot demand excellence from people who feel undervalued, overburdened, and expendable. I understand there's a new EMS director, and I am cautiously optimistic, but this problem is bigger than one person. Our towns gave up local control, equipment, and oversight in exchange for the promise of improved equal care. That promise is being broken. EMS is not a luxury, it is essential, and I will continue fighting until it is treated as such. Thanks.
Thank you.
Thanks.
Are we allowed to sign?
What's that?
Is that?
So, Mr. Chair,
Yes, Clint.
so are we in compliance with the transfer agreement?
I was gonna have that looked into. I think we can respond to her, questions. And, we'll probably go to our EMS group. I think you're involved with that, Trevor. So, yeah, I don't know that we have an answer today, but I think we'll get a response. And any response we send to Mackenzie, I would assume we would probably post on our website or somewhere, so anybody else can see the response. It certainly would be public. information, I think. As far as I know, we are, but, let's find out from Trevor. I haven't actually read those agreements. Abby,
Do we have those notes?
Yeah, absolutely.
we have it recorded. But if you would give a copy to Andrew at some time, that would be appreciated also.
Yeah.
Thank you for your comments, Mackenzie, and for coming.
Thank you.
And Dr. Hauser.
My name's Don Hauser, and I've only been in this valley for 2 years. I'm a board certified OBGYN, and I was in Fort Worth before here for 22 years in the same practice that I started in 2001. And when I decided to make a life change, and it was a big deal, I promised myself I wouldn't get involved in any of this kind of stuff ever again, as I was intimately involved with all of these kind of things in Texas. But I was talking with Mike Hunsaker a little bit last week, and he said, hey, could you come maybe tell us a little bit about your experiences? Because I have a very different viewpoint about what's going on here in the community and with the hospital. And so I wrote a few notes. I wrote a few notes down, but the most important thing to know is that not only am I a physician in the community and here in the hospital now, but my family's been patients here. I've used more healthcare in the last 2 years for my family than the last 20 years combined. Why, I don't know. I had a kid with a broken arm, a college kid with a broken arm that we brought back from New York for surgery. I had another college kid that needed sinus surgery. My littlest one just had tonsils out a few weeks ago. I brought my mother here from Phoenix a week after I got here. My aunt called and said, this is it, she had lung cancer. They're wanting to send her to inpatient hospice. I flew down there. I had a short conversation with her. She was very ill. She'd been there 10 days. I didn't know about it. She hadn't eaten anything. She persistently vomiting, she's belly pain. And I said, do you want to go to hospice? I can't help you from Wyoming. Now, my mother grew up in Cassville, Wyoming. That's my link to the area. But and she does not like Cassville, Wyoming. So when I asked her, do you want to come back to Wyoming with me? It's the only way I can help you. And she said, I'm not ready to go yet. Let's go. I knew she was serious because I never thought she would come to Wyoming. Now, this part of Wyoming, I put her in a Cessna 206, not sure if she would even live the flight to get here. We carried her out of that big hospital in Phoenix. We carried her into this hospital here. 3 days later, she was eating. A week later, she knew what planet she was on. And I had conversations with her every day. But I walk in a week after she had been here, and she said, Dawn, where am I? She had no recollection of the previous week. I explained to her where she was. 3 weeks later, she was out of the hospital. She went through physical therapy here. And I met my promise I gave her the day I took her out of there. And that was, when you're ready, I'll take you back to Phoenix. She lived across the street from her sister, and that was her life. One day I go home, she says, I'm ready to go. I take her back to Phoenix. She had 10 more good months before getting pneumonia, passing away. So the one thing I can say without question, since I've been here coming from the city, is that we have the right people. We have the right healthcare providers. We have the right administrative team. We have all the right ancillary staff. And I don't want to be dismissive to anybody about their concerns or how they feel about things. But in many ways, what I've noticed is that a lot of the public doesn't realize how good it is here. And that's really going to be my message today. So social media gossip is what pulled me back into this. I've had a few patients say a few things, and my wife will pull up something on social media. But I wanted to share my experience in a large metroplex with 4 big hospital systems, community health systems, HCA, which up here, HCA is ERMAC and St. Mark's. They're all over the country, big HCA presence in the Dallas-Fort Worth area. Harris System, which is the largest hospital system in the Northeast Texas, and Baylor, which is all over the state of Texas on the east side. For the past 12 years, I'm going to say since 2012 or so, every one of those hospital systems, including my home hospital, even though I have privileges at many of these others, that's the way it is in the city. You gotta go everywhere. We've been dealing with the financial pressures that are here now on a daily basis. Those financial pressures have included, well, what's the first thing that happens? They take matching away. Matching retirement was, I was in private practice until 2013. When there was a mass exodus out of private practice, I was absorbed by the community health systems hospital there. But matching was the first thing that they take away. Staff cuts, middle management, conversion of departments to contract companies. That was the big thing. I still have friends that were CEOs, 3 of them that I talk to on a pretty regular basis. And I asked Dave one day, what are we doing? Why is our housekeeping outsourced to these contract companies? And he said, because they can do it cheaper. And I said, but Dave, there's only one reason they can do it cheaper, because they don't do it, right? And so all of the quality of those departments decreased in time. But we had conversion of contract companies for housekeeping, for our food services and other departments. And not only that, but things got so tight intermittently. I mean, it'll be 3 okay quarters, 1 bad quarter, 3 okay quarters, 1 bad quarter. But you know, when you shut off the water to the landscaping in Texas, it's pretty dry there. It all dies. So our hospital outdoors look like it's an abandoned building. I mean, it's a degree of financial pressure that, although hasn't been seen here, I can't say exactly why. But when I talked to Derek Koinka and Dave Orcutt and Mike Pruitt about what's going on here, these 3 CEOs that I still talk to on occasion and friends with, that they have one message for me of why it hasn't been here until now. And that message is, your administration team is just good. They kept it away because it's everywhere else. You go outside this valley, you go to Tacoma and Multicare, which is a big hospital system there. You go down to Phoenix, you go down to any other major area, and these kind of financial pressures are on them every day. When we talk about the EMS thing, in the city, you're put in line for EMS, and it's triaged. And they do the best they can to figure out who's the most important person to go out to and pick up first. And then sometimes you're flying around in a helicopter for 2 hours waiting for an open bed in an ER. These are all things that we're experiencing here now that we've been experiencing for a long time in other places. What have I done in the past? I bought TVs for the hospital because I was embarrassed they're broken and they're out of the budget. I cleaned bathrooms and labor and deliveries because I've been embarrassed and I didn't want patients to go in there. I've spent Saturdays and Sundays there cleaning tile that it's just been out of condition because it hasn't been done very well. I've paid my staff under the table extra, Venmo, $150 a week to keep them because they've decreased, they have decreased starting wages so low that they could go work at McDonald's and make more money than come in and be an MA in the office. And then I came here and it was like utopia for 2 years. All of those things were kind of gone, but I walked around and I kept saying to myself, this is not sustainable because of my experiences. And sure enough, we're experiencing some of those. Why? Well, the same reason we started experiencing back in 2011 or 12, it's the insurance contracts get worse. Co-pay, the patient deductibles go up, the patient total out of pocket go up, their co-insurance go up. And when I first started this, $750 was a high deductible back in the late 90s. If you had a $750 deductible, you were getting ripped off. And now you're talking about deductibles that are thousands of dollars and total out of pocket for families that are tens of thousands of dollars. And if you look at any of the literature of all these financial pressures that are going on across the country in these hospital systems, what is the one thing you hear consistently from the CEOs of those hospital systems? They're struggling to get paid. They're struggling to get paid from insurance. They're struggling to get paid for the patient responsibility. I've been in my career down there 3 times where we chose not to renew a contract with an insurance company. The first one was Cigna. The next 2 were Blue Cross and Blue Shield. Blue Cross and Blue Shield was the majority of our insured patients. And the hospital system decided it's better for us to not have a contract and just walk away from it than it is to sign the contract they're offering us. Now, in all three of those situations, it was resolved. The first two times it was resolved before the contract expired. But the third time, we went 6 months without taking Blue Cross and Blue Shield, where 30% of our patient base had that insurance company. We went 6 months before they finally came back through pressure from the public and the patients, before they finally came back and we came to an agreement. So this Cigna thing that I'm hearing about here is, I've said many times since I've been here, I feel like this is Groundhog Day. Everything is happening and recurring, and it's things that I've lived through before. So I definitely have an opinion. What do we have here? We have great leadership team, great medical staff. My father-in-law was in the hospital because he came here to visit and got COVID, and he had to be in the hospital. And he's been in the hospital a lot because he had his legs crushed in an accident by a forklift. And he said this was the best experience he's ever had. Now he's down in DFW, and that's what I consistently hear from everyone, and that's what my experience has been as well. So we have the staff, we have the docs, and we have the independence. Is this community independence of this hospital system sustainable for a long time? I'm not sure. I don't know. It's scary because maybe it's not sustainable. Maybe one day we'll be a part of a big health system that their home office is in Nashville, and somebody's making decisions for our friends and neighbors at a desk in Nashville. And I can promise you, we want to delay that as long as possible, because that's where I was before, because that's exactly what has happened. So I've said, coming here, medicine, to run a hospital, to run an office, medicine on a good day is a difficult process. There are difficult decisions that have to be made about people every day. And there's not anything that I envy about the people who are running the hospital, our CEO, CFO, our head of human resources, CNO, our quality director, Jeremy. All of these people are making decisions that are incredibly hard. If they walked up to me tomorrow and said, hey, Hauser, you're just not part of our business plan any longer, we're going to have to make some changes, I would be very disappointed, but I wouldn't be upset, because this is the world we live in. And I would shake their hand and thank them for the opportunity they gave me to be here up to this point. Moving here, which many of you guys don't know, I came here to change my lifestyle. I was very busy in Fort Worth. I'd worked a lot and I missed a lot. And I came here to change my lifestyle, but I didn't know all the other life changes that would happen. It's been the best experience I've had, not only on a professional level, but also on a personal level. I want to just say that I have, and I don't know the fellow that was up here talking, Mr. Brandon Taylor. I don't know him and I don't know what he does, but one of the things he said is unity is required. Well, the one thing I do know without question, it's not an opinion, is that if we want to be successful coming out of that, the community has to support us. We, the docs and all the care providers in the hospital that go along with it, we just need to focus on taking care of the patients. And we need to let our administrative team run the hospital. As I said, I'm still friends with 3 of those CEOs that I've had over the years. And I can tell you, and I've never said this to anyone, and it's a little awkward because you don't necessarily want to show your poker hand, but this is the best administrative team I've ever been around, hands down. If someone said to me, hey, Hauser, we want you to go open a hospital in Tennessee, I would gather these guys up and do whatever I could to take them with me, because that would be my best chance of success. So I just want the community to know that, because I hear background noise about, oh, someone needs to be held responsible, somebody needs to be held accountable, somebody needs to go. But if that's going to be the process, now that this is finally here, every 2 years when you have a bad quarter, you're going to be letting some of these people go, because this is not going away. Every year we're going to be asked to do more with less. Promise, guarantee it. Some years we'll be asked to do more with a little bit less, and some years we're going to be asked to do more with a lot of less. So I just wanted to come up, share my experience. I've been in much, much bigger financial pressure areas than we're experiencing here, where there's lots of competition, and that adds another level of financial pressure. And let you guys know as an outsider, how I see what's going on here, I think, yeah, it's unfortunate, but this is the world and the business of medicine that we're in. And I could talk about this stuff all day long. I've had my finger on the pulse of financial well-being of healthcare for a long time. I'm on a lot of email threads that I read through. And if I could share some of those with you, you'd be shocked at what's going on across the country. So I just wanted to take a few minutes, give you my opinion and tell you we've got the right people. We just got to weather the storm. Thanks.
Thank you. Yeah, I'm gonna make my comments from the chair here. These are not speaking for the board. This is, it's just me, right, Brandon? So as I listened to the comments and heard about social media, I gotta tell you, I don't go on social media. Don't even know how. I do get some reports from others. I wanted to make some observations to the public. Just reading my notes here. I've been on the board for 15 years. And the board is a unique, in America, it's called a representative form of government. And the citizens elect those that are in the North Lincoln County Hospital District boundaries, elect each of us. It's not a district, it's all. And we represent everybody as Brandon was talking to Abby. But our fiduciary responsibility is the hospital. And I think sometimes that you forget that if we were to go back to the public for every decision, we wouldn't get any work done. It's not a democratic form of government, it's a representative form of government. You've elected this board to represent you to make decisions. And I think we vet those decisions and always have. Each of those, I think probably every one of those years, I attended annual training. You call them retreats. I call them education. The hospital paid for that. They didn't pay me anything for my time, but I went to find out. Excuse me. About healthcare issues. A lot of those were in Phoenix. I remember going there. The last one was in San Antonio. And it's very helpful to be educated as a board member because I came on here 15 years ago thinking that I like to solve problems. And I thought, oh, here's a big one. Maybe we can solve this. And it's too big to solve. It is somewhat of a broken system, but we do a great job here in Star Valley handling this. Let me just express how this board operates. We're responsible to hire one person, and that's the CEO. As I thought back, I think I've been involved in all of the CEO decision and choosing a new CEO, except for the first one, Steve Perry. We've had 3 CEOs since Steve Perry and 3 interim CEOs. Am I right, Mike? Did I get the number right? And each of them were good, had their strengths and their weaknesses. And I would echo Dr. Hauser. I think we have a great administration team now and a good CEO, actually a great CEO. The board approves the annual operating budget. And we just talked about this. We approve the annual capital budget and we approve a strategic plan. which is both annual and looking out years going forward. We have vetted all major decisions that this board has made. I hear a lot about the airplane or other decisions. That's been the high one. These aren't done lightly, under a bushel. We talk about them. We send our administrative staff back to find out questions and answers for us. I'm accused of asking a lot of questions. I guess accused is the right word. Anyway, but I think questions are important. You can talk to any of the staff members. They know that meetings go long because I have some questions. Frankly, that's very important. One of the other comments I read, we have an annual audit by an outside party. In the last 5 years, it was DZA auditors. I don't remember their name. DZA is what I remember. This year we have Ide Bailey, and they're just finishing up that audit. It has taken a while. There's been some special circumstances this year. But every year we have received an audit. For the 15 years I've been here, and I'm sure they were audited every year, but prior to that, every district and board in the state of Wyoming goes through some kind of an audit, whether it's a state auditor or whether it's a third party. And those are available for anybody in the public to go see and get a copy of. And you'll find that each of those has been a clean audit. Are there some corrections to be made or entries to juggle a little bit? Yes. But materially, we represent the financial position of this business adequately and according to general, it's gas. I don't remember what it stands for anymore. General something standards, government standards, right? So Ide Bailey is doing it this year. We're going to hear from them today, I believe. We also have standing committees, subcommittees. We have a finance and construction committee. We have a quality committee. We have an IT committee, which we've just started up. And we can have any other committees that we need. And that's where we look at the details and the vetting of these discussions are made in more detail sometimes than those meetings, especially the finance. We don't have time in this meeting for every board member to dive into all the drill down into the finances. And so we have a standing committee of 3 individuals that drills down. The minutes are available. They're available to you if you want to look at them. They look at the details. Every board member at a board meeting can ask all the questions they want if they haven't gotten with somebody and gotten an answer. So none of this is a knee-jerk reaction, which is the impression I got from the public the last few weeks, is that we just go nilly-milly and make a decision, or the administration doesn't look at things. And my experience for 15 years is that we look at things very, very hard because we're representing the hospital and we want to make sure that we keep staff. Nobody wants to lose staff. You know how much it costs to retrain somebody? I would hate to lose staff. In fact, a few years ago, Tori, you remind me when we chose as a hospital to kind of grow our own in the nursing area. And I think that's actually been a pretty good policy. We have less lack of nursing now. I think we're almost full. In those days, it seemed like every other meeting we were hearing that we needed more nurses or we had traveling nurses. And so we do look at things in great detail. We don't act arbitrary. It's very transparent. I haven't been involved in these 15 years where anything has been non-transparent. And if somebody wants to come and ask me a question, I'm very open. But I can tell you, I rarely have anybody come and ask me a question. I must scare them or something. Maybe I don't smile right. Not sure what it is. But I know other board members sit on this board, get a lot of calls. But you'll know when you talk to me, you'll get facts. and not emotion and innuendo. And if you don't want facts, don't call them. I agree with all the acts of our administration, especially in the last few weeks. I went over those, as I said in the public meeting with our CEO, and I thought those were good. The one thing that I did wrong, and I've apologized to every board member except Abby, I think I haven't got a chance to talk to her. We probably should have met and informed the board of those decisions. You have to realize sometimes I don't think of those things. If it seems right, I just move ahead. And sorry. My wife will tell you that I don't look to the side. And that's not a compliment. And so I apologize to the board that we did inform you so you weren't side. What's the impression? It didn't come out of the left field or you didn't get hit with a brick on various issues, but they were looked at and they were discussed and all of them were, I think, good decisions. Now, I may be a party of one on all of those decisions, including EMS, but I think they were all the best decision that this hospital was made for where we're standing right now. The other thing that I get every once in a while is anonymous emails and letters. And I got to tell you, they have no effect. You don't want to put your name on them, don't send it to me or the board. You can't stand up for what your opinion is. I'm going to stand up for my opinion and you'll know who it is and what it is. And if you're going to send an anonymous one, no matter how good or bad it is, just don't waste the postage. I don't read them. Well, no, I don't. I read them and say, I'm not taking this into consideration because they're not willing to stand up for their opinion. Want to stand up for your opinion? That's great. Those were the observations I've had. This is a gem of a business. We have a great, I don't know Dr. Hauser very well. I've maybe met him once. I appreciated your comments, Dr. Hauser, if you're still here. I agree, and I don't know, I mean, I've gone outside of here and had good health care, but I know I've had better health care when I've been here. Now, I don't try to come here very often. I like to stay away from this hospital as much as possible, especially when it's Dr. Cowan going to treat me on something. So.
Ouch.
So anyway, those were my observations and comments after all the public. I wanted you to know my opinion, where I stand. The interesting thing as I think about this is that every 2 years, actually for each board member, it's every 4 years. You don't like what we're doing, guess what you get to do? You get to fire us. For 4 terms now, somebody has chosen not to fire me. And I don't know that I'll run the next time. But I might run just to find out if you'll fire me. Thanks. Moving on, any other comments? Chief of Staff, your report, please.
Yes, sir. Thank you. All right, the medical staff report for May. Pretty short. We had 1 initial appointment of providers. We had 3 reappointments providers and 12 telemedicine providers that we credential. Those range from radiology to tele-ICU, telecritical care. There were no policies or protocols approved. There was a bylaws amendment proposed to the board. And I can go over that. It's regarding a resident affiliation. This primarily deals with emergency medicine residents. This is a very common practice around the country where a chief ER resident, several months before they graduate, will start moonlighting is the term, particularly at the facility where they intend to work. That provides them the ability to get up to speed. It also provides the staff ability to get up to speed with them. So we'd like to propose that. They are still residents. They are not going to be members of the medical staff. They do not have voting. Of course, they will submit an application that's appropriate. We will receive approval from their residency director for this. And they will provide, obviously, a state license, a DEA, and appropriate insurance, just like any other provider will. And they will, again, not be able to vote. This affiliation will expire 60 days after completion of the residency training. Now, one of the reasons that we did this is we have several ER providers that are in their chief year that have expressed interest in working here. And it's a great recruiting tool for us. This will obviously be under the direction of the ER director, which is Dr. Keel currently. And we watch them closely. This is not a hands-off. Yes, sir.
Are they paid by us? How's that handled on the finance side?
Yes, they are.
It seems like in the past, we've also made agreements ahead of a doctor coming here so that we get them here, because rural hospitals seem to have a little hard time recruiting
It's an
certain
understatement.
types of positions.
Right.
And so I think some of our orthos and others, we were helping as they were finishing up their residency in college. Is that common practice?
So, very incredibly common. There are facilities and municipalities that will actually pay for their entire medical training, which the average, and I'll speak for general surgery and trauma surgery, the average graduating chief resident in general and trauma surgery has a debt somewhere around $400,000. And that is part of the recruiting. They will wipe out that, some municipalities or institutions will. Now, they owe a certain amount of time for that, obviously.
So there's a trade-off.
Correct.
Okay.
Correct.
Thanks.
So, so that is the resident affiliation. Any questions on that one?
Andrea, is that resolution later? I don't see it in our agenda, is it?
It's F on your.
It's item F?
Under,
Okay, so we'll come to that. All right, thank you.
If I may, Mr. Chair, one other thing, just by way of information, so that the board knows this. We have medical school and PA and nurse practitioner school affiliations. We are in the mode of increasing those students with us. It's good for us as providers to give back. It's good for staff to witness training going on. It's good for recruiting. So just to name a few, we have affiliations with the University of Utah, with NORDA, which is a DO school down in Provo. We have mid-level affiliations with Idaho State, Utah Valley University, and Icahn University, just to name a few. We have others. And so the medical staff is committed to increasing the education and providing education for not only medical students, but residents as well. And I get approached multiple times every month by medical schools and residency programs for the opportunity to come on a quote rural track. So, and they don't do that lightly. They've done their research on us as well. So just by way of information. Any questions on that?
Okay.
Thank you.
We're down to our consent agenda. In your agenda there, I think it's not 10 months instead of 9, Andrew, on one of those, is correct. This is the financial results through April. You all had a chance to review those and the statistics and the bills against the district. Is there anything we want to pull out of the consent agenda and ask specific questions about? We will have a report from our finance committee still. This is our monthly financials. Okay, I'll entertain a motion for the consent agenda.
To approve it.
Approve or deny, you get to choose on your motion.
Yeah, I make a motion to approve the consent.
Okay,
As written.
been moved by
I'll second it.
Clint and seconded by, what's your name? Cole,
Whatever you want to call it.
to approve the consent agenda. Any discussion? All those in favor?
Aye.
Any opposed? Okay, no unfinished business. We'll move on to new business. Cole, would you give us a report on the finance and construction committee meeting?
Yeah, absolutely. Just, I made a few notes here, want to kind of just touch on, go over. Scott, if you want me to, take a second and veer over into the audit report, we can do that too. I'm not sure if we had a time set or.
As soon as you're ready, the audit partner will join us on that next item of discussion.
Okay, perfect. So just wanted to touch on a few things. We met last Monday, went over, or Scott presented and discussed, April 2025 financial results, along with some changes to the 2024 year-end financials. As part of this discussion, the audit firm Ide Bailey joined us, for discussion, an explanation of the changes being proposed. Ide Bailey, in review of subsequent payments and adjustments flowing forward from 2024, found that the contractual allowance reserve at fiscal year end of 2024 was inadequate. And while a lot of it was accounted for in 2025, it should have been accounted in 2024. Essentially, this moved about 7.2 million in contractual allowance reserve and bad debt adjustments from 2025 into fiscal year 2024, meaning the fiscal year and 2024 numbers were previously overstated, and fiscal year to date 2025 were understated, or previously understated. This was due in large part to timely filing adjustments, including some stuff with Change Healthcare, claim adjustments due to the Epic build feature that had major contracts entered into Epic to automatically produce claims for the contracts. This feature was found not to work and was rectified in November. However, overstated, miscalculated amounts on claims eventually had to be adjusted off. Ide Bailey also believed that there would have been no real way to have seen this or seen this issue ahead of time, and that the system wasn't taking the adjustments. A couple other notes I wanted to touch on that I noted when we visited with Ide Bailey specifically, and questions that I'd asked and posed or another board member had, and we got answered. But Ide Bailey noted that this was actually a benefit for them to not have the fiscal year 2024 audit complete. Yeah, as they wouldn't have been able to see the issues or foresee the issues with allocation and time of filing, and been able to make those adjustments. Because of the lag in getting the audit complete, they were able to appropriately account for those in the appropriate fiscal year. Ide Bailey also noted that they viewed this as a perfect storm between the electronic medical record system changeover and Change Healthcare hack, and discussed that or noted that. We also discussed some of the audit timing issues, and I'm sure we'll discuss this in more detail here shortly, but essentially it was related, they noted that a lot of it was related to new software and learning curve for staff. There was 100+ journal entries that were made. Some of this stuff that had to go back to the previous electronic medical record system, which allocated more or took more hours from the audit firm, as well as the staff, to account for all the details needed. There's lots of back and forth. They had about 3 times the hours to complete the audit into it. And some of the other challenges were changes in pricing and contracts that affected a lot of it as well. Going forward, reconciliations are being done monthly. to help with this and to assist with this and a more timely audit in the future. A couple things I want to just touch on as far as the audit or the adjusted financial summary. So Scott was able to provide us with adjusted financials for fiscal year through or 2024 through April, which is our comparative of fiscal year to date.
25 through April have been adjusted.
And on the ones that we got in financial committee, we were looking at the comparison back to April of 2024, right? And so you had those adjustments made in there per I Bailey's recommendation. Essentially what it did is fiscal year 2024 through April showed a revenue shortfall relative expenses of about $2.9 million. When adding back depreciation and interest expense, it basically yields a positive $2.5 million essentially at the end of the day for this, basically cash to service debt requirements and cover liabilities. And that's through April of 2024. As far as fiscal year to date numbers through April in 2025, it's showing it adjusted this to $2.7 million in excess revenue over expenses. Again, when adding back depreciation interest expense yields a positive $9.5 million in fiscal year 2025. Again, that's to service or to cover all debts and liabilities of the organization. Days cash on hand is running in the 60s at the end of April. Scott provided us a days cash on hand forecast previously and kind of gave us three options: a best scenario, a likely scenario, and a worst scenario. And we are tracking along with the best scenario right now. So there's been a lot of cash collected. There's been a lot of improvements in revenue cycle, cash collection, the whole process in general. Days revenue and accounts receivable is down to 75.9 as of the end of April, which was down from 85 in March. The significance of this is we're collecting our invoices, our bills quicker, by about 10 days quicker. That's a huge improvement, both in cash collections, days cash, maintaining our days cash on hand while paying down short-term debt as rapidly as the organization is a huge win. And the decrease in days revenue and accounts receivable is a major win for the organization as well. So two very positive things there. We did talk about some strategies going forward. There were some things that were already in place and have been in place. We brought on enterprises to bolster cash collection on self-pay accounts, and they have been actually, pleasantly surprised with what they've been able to collect at this point, my understanding. There was a coding audit that was performed, and are also looking at bringing a consultant in and to help with the processes side of things. With that, we also reviewed disbursements on the district and didn't find anything that we had issue with. We reviewed a preliminary budget and CapEx expenditure that needs to be provided to the state by June 1st, I believe, correct? And a final budget and CapEx budget will be reviewed in June for further detail, further review. And then lastly, just future CapEx projects are on hold. Any questions?
Can you clarify? We used to, at end of fiscal year, June 30th, and over 12 months in arrears, and you're saying that a month at a time we're sending the information over? Did I hear you say that?
There is a monthly reconciliation so that when we provide the information to the audit firm, we've already reconciled
It stays in-house.
up
It's
to
still-
that month.
yeah.
Right. And so that's one of the things that hopefully that makes the audit a lot smoother going forward.
So, Cole, are you saying that I Bailey is in effect, basically audited up through the end of April of 2025. Go there and look at.
Well, no, I don't think we can say that, but, why don't we bring on Scott
Okay,
and let him maybe answer your question.
so this is, Scott Wimler?
Nelson.
No, Scott Nelson, the partner. Sorry about that. Not Steve Wimler. All right, I got the names right.
His go-to guy.
So, or you have anything else, Cole? We'll
No,
go.
as long as I can answer questions, if anybody has questions.
Any questions for Cole at this point? Why don't we hear from, our partner at Ide Bailey, Scott Nelson? Tell us about our audit. All the fun you had.
Mr. Chair. Each
Just a
of
minute,
you
Scott.
has a copy of the draft audit,
Okay.
basic financials as they stand now, and Scott will address the
You
two
should have
things that are
this for.
necessary to get that all finished up with the footnotes and all that, which is only a couple days. away.
It's this handout right here, board.
He may refer to some parts of that.
Thanks. Go ahead. Scott Nelson.
Good afternoon, everyone. As mentioned, I'm Scott Nelson, audit partner with Ide Bailey, coming to you from Billings, Montana this afternoon. Bear with me one moment and I will share a short slide deck that I have for you today. Hopefully that's coming through loud and clear.
It is.
Yes, sir.
Perfect. All right. As probably has been mentioned by Scott Graham, our deliverables are currently in draft form, pending a couple last minute items. Once we issue the financial statements, the reporting package will include, our opinion on the audited financial statement. Included within that will be our report on internal control and compliance. In addition to the financial statement audit, we do perform a single audit, that governmental compliance audit over federal programs, as well as a report on your statement of expenditure of federal awards, or otherwise known as the CFA. And lastly, we'll issue our management letter, or otherwise known as a report to the board. We do intend to issue an unmodified or clean opinion on the financial statements and that CFA report. I will mention that we had no compliance findings related to the last of the federal COVID funding that was recognized in 2024. We are very, very near the goal line to issuance. However, we require waivers of the financial covenant violations from your lender associated with the revenue notes. We cannot issue without those waivers. And maybe Scott can jump in here in a little bit, but I believe management and the lender met this morning again and are working towards obtaining those waivers. And just a little color to that. The reason this is so critical for us as auditors is because in the absence of those waivers, your revenue notes totaling about $24 million could potentially all have to be portrayed in the financial statement as current liabilities. If the bank were to theoretically call the debt and not provide that covenant waiver. Now, I don't think that's going to happen, but just to give some context of where we're at there. And Scott, I don't know if you want to jump in as far as your meeting today with the bond council.
Yes, if I may.
Yes, Scott, because I was going to ask the question anyway. Go ahead.
One of the complicating factors this year is we added two entities to the audit. In the past, the hospital itself has been audited. This year, we added the imaging center, which we acquired majority interest and controlling interest in at the beginning of the fiscal year. And it was determined that the foundation was a material component unit that must be recorded with the hospital's financials. So instead of one unit, you had 3 entities, independent entities. Of course, the hospital is the biggest one, but it did take our audit firm some good work to audit for the first time these entities, the foundation itself had been audited. And then the imaging center, they had to audit the beginning balance sheet and then the period under audit and the ending balance sheet. But the reason I say that is that there was some discussion with the bank of based on the loan agreements, which entity do you use to compute the debt service covenant ratio or cash on hand ratio, or number of days cash on hand. And so we got the bond counsel, his name is Rick Thompson, involved this morning with Mike Mueller from the bank, and clarified, what the bank really has full prerogative to call it how they want to see it, because they're the only lender, right? If there's other bondholders, it'd be different. So now that was clarified this morning, Mike Mueller is running this right up the flagpole at First Bank. And he told me it'd be several days before, just to go through the process of, presenting the story, how it's computed, and get the waiver needed. So that's what the discussion was this morning, Scott, and it's pretty clear. And, there was no ambiguity with the bond counsel at all.
So, Scott Graham, what are the covenants that we have with First Bank? Now, just help me understand, First Bank, we have revenue bonds with them, which is basically debt.
They're notes, but not bonds.
Notes, but not bonds, excuse me. They're notes. They did not sell them. You're right. So they didn't become bonds. So they're debt that we have. Are we in trouble with our local banks? We got any problems there?
This was the 4th year of missing a covenant. I think we would, but it's not.
And what is the covenant?
There's two financial covenants, and then there's another information delivery covenant. There's a debt service covenant ratio, which is a ratio. It's 1.3 to 1, and the 1.3 is the amount of the resources available to service debt, interest and principal payments on long-term debt obligations.
Are we okay with that covenant?
We will not make that covenant. But the indication from the bank is that they will waive that.
Well, where are we at then? If it's not 1.3, what are we at?
I haven't computed it the way that we did it this morning. It's probably less than 1 this year.
Okay.
In the past, it's been over 2. So.
Okay.
The other covenant is days cash on hand, which is 100 days.
Okay.
And, last year we made it, or the year before we made that, and this year we'll fall short by probably 9 to 10 days.
Okay.
As of June 30, 2024.
That's what we're anticipating.
Right. But I'm not sure, because Mike's going to go back and make, do the computations. He has all the numbers now and the direction from the bond counsel. And the other covenant is a covenant to provide the audited financials 270 days after year end, which we missed. That was the end of January.
Okay.
And it'll probably be the end of this week or next. So we got a waiver there, but I think they'll extend it another 2 weeks is what we were told.
Okay.
So that is the current status of the covenants right now.
Hey, can you tell me, have we missed any payments to the local bank?
No, that they're automatically taken the day to do, so we don't.
Dang.
You don't even think.
Okay.
We're all of our long-term debt and obligations under what are called right of use assets, obligations related to capital leases.
Yeah.
Are current and fine, but.
Chairman,
Clint, questions?
these covenants, is that a monthly requirement or is that a fiscal year end?
Annual fiscal year end measurement only. So, measure once a year. Okay. Is that good for you, Scott?
Yeah, I think the only thing I would add there is, if I'm not mistaken, written within those covenants, and correct me if I'm wrong, Scott, if you happen to miss those financial ratios, is it just 1 period or 2 periods where you may have to retain a management consultant to
Yeah,
revenue cycle.
That's true. It's two cycles in a row.
Yeah.
Then the bank has the opportunity to engage or require us to engage an outside party to, kind of help us or give an outside opinion on what's causing it, the issues. So, but that's not the case. So we're not in the case this year. We don't anticipate to be in a violation next year.
Yes.
Can you clarify? So we're saying we're out of covenant from fiscal year 2024.
Yeah.
The next one's rolling up almost due. You're expecting that to not be out of covenant
Yeah, well, we're well within the debt service covenant
now?
now.
Good.
We're 10 months in, so I think we'll be fine there. The days cash on hand will be close. If not, it won't, if we don't make it, we don't make it, but we could borrow to make it, but I hope we don't have to. But these are some discussions. The bank is well aware of where we're at and very supportive. All I can say is just been very supportive and helpful.
My last question. So is the audit just managed by the bank for the loans that we have? It's not something that's coming from like the state, the county?
No,
anything tied with that?
This board engaged the auditor
Yeah, I remember that.
and it reports to the board of trustees, and then the bank gets a copy of the audit.
Mhm.
Well, with some other parties that are interested, we have a leasing company that wants an annual. A lot of people ask for our audit.
State of Wyoming, I think.
State of Wyoming is, de facto, we give them, the audit opinion report. So
We do that or we're mandated to do that?
it's required that we.
State of Wyoming, I think, is required.
It's required. We're required.
The other ones that he's talking about, I think, are covenants we've made, so we're required because
On the bank end?
we borrow money.
We don't have any covenants with any other institutions other than First Bank.
Just from public comment, we need audited. Something we do, I just wanted to be very,
I don't know
clear
what-
why we do it and what, that's the
And
norm.
it's always been done, as far as I know. I mean,
Mike, when did we start our first audit? First year you were on the chair.
It would have been for the balance of fiscal year 99.
Okay,
as long as we've been a county hospital, it's been required.
so we've had an annual audit since 1999, not 1899, 1999.
Turn of the century.
Turn of the century. Okay, thanks.
Thanks, Scott.
Okay, just a couple comments just to address this slide, and then I'll move to the next. But from our side, being a first-year audit, just firm policy is we have a second partner take a look at the file. And we are just in the process of finishing up that process on our side, but just to let you know that there is a second set of eyes taking a look at the final work product beyond mine. And lastly here, the financials only present a single year, so fiscal 24, and more on that in a bit. Just a couple blurbs here as to where we focus as auditors throughout the course of the audit. The items that I'd like to draw your attention to would, one, be significant estimates within your financial statements. As Scott just mentioned, there's 2 new component units, both the imaging center and the foundation, that certainly warranted quite a bit of our time. Your leasing activity and what we refer to as SIBIDAs, or subscription-based information technology arrangements that require right-of-use assets and liabilities, corresponding liabilities associated with those software arrangements. Last but not least, there was a new audit standard, GASB 100, that was required to be adopted in the current year. Just a couple blurbs on each of those. Just a reminder, the estimates are an integral part of your financial statements, and we devote a significant amount of time and effort throughout the course of our audit on them. I always like to say, if we had 8 hours to audit your facility. We'd spend 6 on estimates, 2 on the rest of the areas of the financial statements, and probably skip lunch. As far as those new components, you know, we're really taking a different approach to the financial reporting entity than you've had in the past, in that foundation and the imaging center are now considered blended component units of the district. That did result in a restatement of your net position or your equity position as of July 1, 2023. Just a side note there in regards to the foundation, we do believe that the foundation should have been included in your 2023 and prior years reporting. For the least amount of pain in financial reporting due to this issue, as I mentioned earlier, the financial statements are presented as just current year only with a restatement of that beginning net position number. Additionally, the district acquired a 53% controlling interest in that imaging center effective July 1, 2023, and that did require inclusion in the reporting entity as a component unit.
Hey, Scott, could I make one comment here, just so the board knows?
Sure.
The imaging center was basically, the bookkeeping was done by a CPA firm that they were never audited, and it was done on a cash basis, not an accrual basis. It had nothing to do with GAAP. So it took a lot of our time and the auditor's time to kind of, you know, reshape what the financials were in accordance with generally accepted accounting principles instead of a cash basis, basically to minimize taxes for the partners. One reason. But just so that there's, when it talks about the adjustment of that beginning net position, it's because all the cumulative effects of bringing all that into a GAAP, just a starting point that was in conformance with GAAP, so they could go forward. That's why there was this one-time adjustment, which he mentioned.
Okay.
Thank you, Scott. Last point here on the slide, you know, the entity has adopted a new accounting standard, GASB 100, accounting changes and error corrections. This particular standard made subtle changes on how we deal with accounting changes, and in particular, how changes to the reporting entity are treated. And the timing of the adoption of this standard was a bit ironic in that lo and behold, we had to fold 2 new entities into the financial statements in the current year. Be that as it may, just making you aware that yes, there was a new accounting standard adopted. It's big news on the accounting front, maybe not so much for you guys. Talk a little bit about the estimates within your financial statements, and I point out the 3 most significant items there. Collectability of patient accounts receivable, reserves for self-funded health insurance claims, and lastly, reserves for cost report settlements. The collectability of accounts receivable, this reserve is the largest and most important estimate within your financial statements. The reserves for Medicare cost reports, maybe not quite as significant to the financial statements, but important nonetheless. And the reserves for self-funded health insurance claims, meaning you're self-insured for that liability with a reinsurance policy backing those, but there's an estimate within your financials to estimate the claims incurred but not reported. So you may well know that it takes a little while for an insurance claim to work through the process. When one of your employees goes and sees a provider, there's a time lag as far as when that claim actually hits your insurance provider. So we have to make an estimate at year end to kind of account for those claims that we know are out there, but haven't made it through the system, if you will. In regards to collectability of accounts receivable and the self-funded health insurance claims, I would say that the methodologies used to determine those estimates showed some inadequacies at year end, and just based on the audited results. However, as adjusted, each of these reserves we believe are now fairly stated based on the facts and the circumstances as we saw them and the audit evidence that we obtained to support those reserves. Furthermore, we as auditors, we as auditors have the benefit of hindsight when we perform a retrospective look in order to audit these reserves. So we not only take a look at a waterfall analysis, if you will, to take a look at the prior year estimate and how did that turn out against the actual results. But we also take a look at what happened subsequent to year end. Kind of the benefit of hindsight that maybe isn't employed or able to be accessed, if you will, by Scott as he's setting those reserves at month end and ultimately at year end. I will tell you that we looked at the run out of the 2023 employee health insurance claims that were paid in 2024, and we did determine that the reserve in the 2023 statements were understated by approximately $1.1 million. That was a miss on that estimate that really resulted in expense in the 2024 financial statements as benefit expense due to that miss that should have been in the prior year. In that waterfall analysis where we looked at the prior year allowance for uncollectible accounts receivable, so your patient accounts, that reserve went the other direction, but it was likely overstated in the prior year to the tune of about $762,000. In regards to the accounts receivable allowance, and I'm fast forward to year end here, we did propose an adjustment of $7.2 million to increase that reserve for uncollectible accounts. This was the result of what I would refer to as a perfect storm, and a number of factors led into this. So it wasn't just one sole issue, but by far the biggest and probably most pertinent contributor, if you will, to that was timely filing losses resulting from the Change Healthcare disruption in billing. So you would outsource to Change Healthcare to do a significant amount of your patient billing, and Change Healthcare got hit with a cyber attack and caused a severe disruption in that organization. And quite frankly, they weren't processing your claims in a timely manner. In addition to that, the allowance modeling that was using too low of write-off percentages to estimate write-offs, and probably a side effect of that Change Healthcare disruption that I just referred to. Another item that affected this, certain system conversion issues and how claims payment processing was being treated, I think affected the allowance modeling data as originally was set forth. Another item there were adjustments to record additional revenue just related to the filing of your own patient claims that increased accounts receivable, increased revenue, but did warrant additional allowance as a result of recording that additional revenue. As those claims were ultimately coded and billed to the insurance companies. Just there's a time lag there, but it resulted in a pretty significant increase to revenue and AR. Last but not least there, we did notice a pretty significant buildup of credit balances on patient accounts, which were probably deflating gross receivables within the allowance modeling. I think that buildup of credit balances was likely a result of the revenue cycle team getting ramped up on the new Epic billing software and probably not paying as close of attention as they should have been to amounts probably due as refunds to individual patients or payments due back to various insurance companies, be it Blue Cross, United Healthcare, whatever the case may be. Next couple slides, I've got some snapshots of the financial statements. These are certainly condensed information, but I think it gives you a picture of where things sit. The first slide here is a picture of your statement of net position.
That's in your handouts.
This combining information for the three entities now included within the financial statements, of course, the district, the imaging center, and the foundation. You will notice a fourth column there on this slide labeled eliminations. So just make you aware, any inter-entity or inter-company transactions between the three entities are basically eliminated from the total column and what rolls up into the actual balance sheet, P&L, statement of cash flows, so on and so forth. The entities combined total assets just north of 109 million. You have combined liabilities of 60 million, about 300,000, and a combined equity or net position of 49,177,000. Take a quick peek here at your revenues, expenses, and change in net position. You can think of the change in net position as your net income or net loss, as the case may be. The facility had combined operating revenues of 89 million, expenses of 95.5 million, resulting in an operating loss of 6.5 million. Taking into account combined non-operating revenues, throw in the grants and contributions related to the foundation, the change in net position was a loss of 2,748,377. Once you get the issued financials and really depicted here on the graphs, you'll notice that term minority interest within the financials. I'll just point out here that this reflects the 47% ownership of the imaging center retained by the other physician owners. So the combined financial statements carve out the piece of that particular component unit that's not owned by the district. I have some internal control comments to review. First two items there, auditor preparation of financial statements and CFA, as well as lack of complete segregation of duties. I will tell you very common findings that we have for nearly every facility that we audit. The first one there, we as auditors prepare the financial statements and the schedule of federal awards as opposed to management, which by default we consider a material weakness over financial reporting. Secondly, a limited size of office staff prevents complete segregation of duties. so that no one person handles transactions from inception to completion, or cradle to grave, if you will. As part of our audit, we did propose material audit adjustments to the financial statements. These affected a lot of areas of financial reporting, including the component unit accounting, patient accounts receivable, the allowance for contractual adjustments, prepaid expenses, fixed assets, accounts payable, accrued expenses, contractual adjustments, net assets, patient revenue, other income and expenses. So it covered the whole gamut. In total, there were 69 journal entries posted throughout the course of the audit. As Scott mentioned previously, both the imaging center and the foundation had never been audited before. So I would say there was probably a lack of appropriate accounting, which was inherent because the audits had never been, or the numbers had never been subjected to an audit previously. But there was significant effort to audit both entities, including their beginning balances, and to ensure their reporting was in accordance with generally accepted accounting principles. As a result of all those journal entries, I would say, unfortunately, we were probably auditing a moving target in a lot of respects throughout the process. And we had a lot of additional time incurred to complete the audit. I would say we incurred probably 3x the anticipated hours that we had budgeted at the outset. However, I do believe a lot of the struggles that caused the delays in 2024 should be in the rearview mirror now. And I do look forward to a much more timely reporting cadence in terms of the fiscal year 25 audit. And I've had a lot of discussions with Scott over the course of this process, and he assures me that the reconciliation and review process has been greatly strengthened in fiscal 25. Additionally, I believe some of the woes created by the system conversion, meaning moving from the Meditech platform to the Epic and Lawson, should have eased. At this point, I would like to open it up to any questions.
Any questions, board or auditor? So just make sure I understand the note there are no material problems with our 2024 audit that you're expecting. I know we have a few cleanup things to do. Nobody's embezzled any money. We haven't lost money out of our accounts. Any of those things happen?
We did not find any evidence of fraud.
Thank you. Any other questions, board? We appreciate your time then, Scott Nelson. And we'll look forward to seeing a final audit.
Thank you.
Thanks, Scott.
All right, thank you. Hopefully the rest of the agenda is short.
Hopefully.
Yeah, I know better.
Thank you for your time. All right, moving on.
Hey, Mr. Chair.
Yes, questions? Oh, finish up here.
Can I add a couple comments?
Please.
Here just to end,
Yeah.
before we move on to the proposed budget and whatnot. So I just want to make sure that we understand as we talk about, I'll talk about covenants aside, the financial indices of
that we're looking at as a covenant, we need to understand the importance of those, right? The importance when we talk about debt service coverage ratio and a miss of, the covenant's 1 to 1.3, but a miss of even be a 1 to 1, we're not break even, right? And if you look at the financials, the proposed financials, the inclusion of a $2.7 million of capital, of a grant, that's a one-time. So, when we talk about a $2.9 million shortfall, really you should remove the one-time, I guess, grant out of that, and it looks a lot worse. Point being is, okay, so the importance of the debt service coverage ratio is to show that we're solvent in every year that we cash flow in that year. But more importantly, it brings to light the importance of days cash on hand, which is when we do have a shortfall of, say, when we go back there, you're knocking on the door of $6 million when we remove that capital grant. That's a lot of days cash on hand. And the whole point of having days cash on hand is to cover those shortfalls without having to pull other levers. Right. And so I think that as a board,
Having to borrow money, is that what you're saying?
borrow money, reduce staff, look for money in other places.
Changes in operations.
Changes in operation. That by having days cash on hand, you cover that without having to go back, make a bunch of changes. I mean, that's the importance of it here. So I think we need to understand that as a board, as administration, organization as a whole, community, the importance of these financial indices is beyond what a covenant represents, right? And so I think there's things there we need to be well aware of what they mean. I also just wanted to touch on, I just going back to the overall report. To me, at the end of the day, the change going from, the $7.2 million being moved back into 2024 versus 2025 really allocates where, things to where the issues were. And I think it allows the organization to move forward. And I think the other thing is it tells a story that there's been a lot of things that have been put into place leading up to some of the stuff coming out, some of the stuff being talked about, scrutinized. There's a lot of things that have been put into place before that we haven't been able to see the benefit of, that we are reaping the benefits of now. And so I think that it's one of those things that I know last board meeting, myself, I think Marlo mentioned this, that, the sky's not falling. And this is why we're saying the sky's not falling is there's a hiccup and there's some issues that we had to address as is shown by the financials in 2024. However, we are moving past that. And I think that some of the stuff I talked about, the days in receivables being down, some of that stuff, days cash on hand being maintaining while reducing much short-term debt. Those are all very, very positive indicators for the organization. So anyway, I won't keep going.
Mr. Chair, one thing that
Yes, Scott.
I just added a few minutes. Failed to mention the receipt of the $2.7 million employee retention credit, which we've been waiting for 2 years. In the last 3 weeks, we got that. So that was a big help to bolster the cash as well. So that was, just wanted to mention that. That's going off the balance sheet, which has been hanging there for 2 years.
Mr. Chair, can I make one?
Yes,
comment?
cool.
So also with that, Scott, though, I don't want to take away from the fact that, or we don't want to take away from the fact that we're collecting more cash than the organization's ever collected, right? On a weekly basis, conversations. I know sometimes it's still not where you'd like to be, but since I've been on the board, we're collecting far more cash than we have previously, right? On a weekly basis, which is very positive.
Yep, comment?
Yes, thank you, Mr. Chair. I think also just for the benefit of the minutes, for the public, not taking anything away from what Cole said, because I agree, and you have to keep those covenants. If the one-time receipt, the atypical receipt for the for the employee retention credit, may make it look better than it really is. I would also suggest that it's a one-time negative on the timely, the timely receipts and the failed performance of a subcontractor, which is also atypical. And so if anything, there was perhaps a blessing to have an atypical negative offset by an atypical positive. And what we really should be looking at is the direction that we're heading, and which I think where you concluded, which is that if management has a plan for changing the correction of our days cash on hand, and we're at or above the best case scenario, those are, I think, some all positive signs for us heading into the future. I just feel like it's important to answer that in the minutes as well.
Great, thanks. Other questions, comments?
If I may interject.
Go ahead.
Sure, and I was probably remiss in pointing this out, during the slide presentation, but I think it's important for everyone to understand that, well, it's not ideal timing as long as this audit drug out. It did allow us more time to look at how you were ultimately getting paid on the accounts receivable that were recorded back at 6/30/2024. And because we were able to take a longer look at that, or had more time to look at that payment and activity, we started seeing those timely filing adjustments occurring and recognize that we've got a problem here. And some of these didn't occur for a year after the original data service, when the facility saw that original payment. We wouldn't have been able to see that had we not gone the additional time and took a longer look at a time period for those receipts and how those claims were ultimately being paid. I preface all that to say we would have ended up with a misstatement in your fiscal 25 financial statements because had we not booked those timely filing adjustments back to 2024, you would have recorded them in your fiscal 25 financial statements when they belonged in the previous year. So I think it's important to understand that we would have had a misstatement in both 24 and 25 had this audit not drug on as long as it did and allowed us a longer snapshot of how those receivables were really turning out.
Well, that's an interesting blessing. All right. Anything else?
One
Abby,
clarification.
yes.
I don't know who it's to, but maybe kind of cool. You said that we're collecting more daily than we ever have before. Does that reflect like an increase in charges? Is it like give me an idea of what that looks like to you? Because if you double your charges and we're collecting double, it's still,
Mr. Cole, go ahead.
So it's a result of the efforts of the cash plan. So as you see these accounts receivable going down, that's because there's more cash coming in from the collections themselves. And so, we've talked about in the past that having all this build up money out there and trapped in cash in your accounts receivable because you have this consistent trend of increasing accounts receivable. Well, now on the flip side, that's starting to come in, trickle in because it's being collected. So a reduction of 10 days in accounts receivable is very significant from the cash that's sitting out there. I think we're down to trapped cash now. And the ideal when it's calculated going back to 60 days in accounts receivable as being the goal to get to target. I think now we're down to having trapped cash of like 5.2, somewhere in there as of the end of April. And if you go back, it was as high as about 10, 11 million, I think, at one point. And so that it's a result of cash coming through, collecting money faster. So we're billing for procedures quicker. We're collecting the money quicker. It's just a result of that. But I think at one point we were actually collecting $500,000, right? Was it a week or was it half, is about, it's 500 some odd thousand in cash collections coming in the door.
That's 10 million a month.
A little more. So I was thinking, well,
You're thinking of,
maybe it's,
you might be thinking of the payment that we were making.
that was in,
Against the Optum working capital. We to reduce that, so it's bringing in just that much more cash quicker.
I was thinking it was on your page report that we were collecting
That's per day.
per day. So yeah, it'd be per day. So that'd be, we were, at one point, we're upward of 500,000.
That's our goal.
And
Should be it.
we're not there. It's slumped off a little bit, it looks like, but we're still significantly higher than we've ever been since that's been tracked.
Thanks. Other thoughts, comments? Let's move on to the budget and capital expenditure. This is a preliminary budget capital expenditure. You have that in your packet, I think. Do you have any questions on the operating budget? This is a preliminary that we will send to the state of Wyoming, correct? But we will, this is not our final approval. If we have questions, we have any changes, at our next meeting in June, we'll have a final operating. I call it a budget. Scott calls it a plan. The operating plan and the capital plan. I'll try to get my language right, Scott. So let's first talk about operating plan. Scott, Scott or Dan, you want to make any comments?
Hey, Mr. Chair.
Yes.
Just to clarify, the preliminary budget due to the state June 1st. So Carrie, Somerville, and I will either tomorrow afternoon or first thing Friday get in their prescribed format, which is, much more detailed, present or ship off that preliminary. And then the final is due July 31st or sooner. But we've got a couple of newspaper postings already set. We have to run 2 before we have, the public can.
So our public hearing will be in June.
The June meeting will be
June
where
meeting.
the public could ask questions about that final
Then
plan.
we have a final budget set. Both capital and operating. Does it, both budgets go to the state?
Just so that everybody kind of knows the cycle and.
So you have before you proposed operating plan. Basically, looks to me like break even next year in 26. I'm rounding. At 40,000. That's great. We're expecting to, net revenue should be at 119. I went back and looked at the past audit since 2019. And in 2019, our net revenue was just under 50,000.
50 million.
50 million.
Speaking of.
Sorry about that. I got my decimal wrong. You're right. You don't like 50,000, huh? All right.
Add 3 more zeros.
50 million. And each year it's grown until this year, the audited 2024, I think was 87.4. And that isn't a 1-year change like I heard out in the public. That's since 2019. Even during COVID, actually it increased a little. I was surprised going back. Each year we've increased that, and I think that's good to note. I don't know. I just made some notes as I looked. Our net position has grown every year since 2019. Some years more substantial than others. 2024 was not a substantial growth, but it was a growth. So I was kind of surprised that just informational, I guess, for the board. Anyway, here's our proposed operating budget. I assume we'll have a recommendation or something maybe from our finance committee. Or are there questions first? Any questions? Benjamin, please.
I have a question. Are we doing operating now and then we'll do capital in a minute?
Yes.
Okay.
I'd like to separate those
Okay.
two.
Mine's on the capital, so I'll wait.
Okay.
Yep.
And does anybody need an explanation of the waterfall exhibit? which basically starts with even a for depreciation number for the end of 24. Yeah. No, end of 25, what we're projecting, end of this year in June, excuse me, and what, and it basically, it decreases a little, excuse me. So we've got an 8.6 that we're starting at, projected for this year at the end of June, and our plan would put us at 7.3 million. Did I get my decimal right, Scott? On the EBITDA for the 26 operating plan. And then you have the line items that goes through. You can look at. Any questions on operating? We're not really having a motion. Are we having a consensus on this?
Just to, Jeff,
Yes.
under that waterfall graph, they're just the high level assumptions baked into, the revenue, the change of the revenue, purchase services and professional services. Those where we'll see some pickup or less expenses and more revenue. And then on the headwinds, the red boxes, if you will, is kind of where we think we'll have more expenses year over year not necessarily driven by revenue, particularly the health plan expense being the biggest year over year. That single item, if you will.
So, and I had some questions on that. I was wondering just in our preliminary here, is that mostly volume or is we got a rate increase in that too?
Revenue?
On revenue, net revenue.
There's both. So we have price protection on our managed care contracts up to 10% this year. And so we anticipate a price adjustment, mostly up, but some up and down probably. We'll massage that as we look at a couple of things. And then a normal trending of the volumes that we've been recently experiencing. We didn't see any of this hockey stick. We just were conservative in the growth trajectory of the volumes currently. Okay. With a more moderate increase in rates overall, just a blended increase in rates. So that gave rise to the 6% increase in net revenue.
Okay.
But I mean, it's quite a bit less than past 6 years. And that's a lot less.
Okay, so my question still stands. I don't know that we need a motion on this preliminary budget. We need a consensus that this is what we're going to send to the state.
Yeah, so Mr. Chair, the way it was presented to the Finance Committee is we wanted just to, because we're submitting this to the state, we wanted the Finance Committee to be aware of it. And then also the board to be aware of it. This is where we're headed when we actually seek for final approval in June, which would then allow for us to have final approval for the state in July.
Will there be significant differences, do you think, or just tweakings?
I don't think there'll be some tweaking. The way we build the budget is like from the ground up and from the top down, and we try to make it all mesh in the middle. So we're really close to making that connection and making sure there's good support, but keeping a kind of a lever on the top line and on the expenses so that we can push if we need to in the departmental budgets, which we do, each department has planned.
Okay.
So there's really no action.
I think, yeah.
All right. Anybody have any real trepidation of sending this to the state as a preliminary budget? And I assume, I haven't heard anything from the Finance Committee otherwise, so I'm going to assume that we're good to go. Okay.
Yeah.
All right, let's move over then to the capital budget. Mindy, you had a question?
I just had a question on the special project capital, the Diamondville Clinic. We have 2 million in there. That's still on hold though, right now, right?
That's correct.
That's correct. Yeah.
And we're not gonna do anything until we're back, right?
I have an update.
You have an update?
on,
Okay.
on that in my report.
And so is that So the 2 million, is that on top of what we've already spent? Is that in addition?
That's an addition.
Yeah, we've spent, $330,000 to buy the land, do some demolition and some, engineering work.
How much total have we spent on Diamond Bill already then?
Approximately 350.
Yeah, about 350. 326 for the
2
land.
million, this includes the building and
This is correct, yeah.
I thought we had some of this year's capital budget
I
already.
did too.
We did.
So is that on top of
This
this?
is on
This
top
will
of that?
restate-
No, this would be the total. There wouldn't be any in addition.
So what we have on pause in this particular fiscal year, which is like $1 million, wasn't it? Or
Right.
did we have like $1
And we
million?
spent a portion of that with the land.
So we have
purchase.
like 700,000-800,000 left over this year, but it's on pause. What you're saying is the 2 million is restated. We're not get
Correct.
700,000 plus. two.
Plus the 2 million.
Yeah.
That's a good
Yeah.
question because I had the same question.
Yes, that's correct. Thanks.
So this would not include what we've already spent. So we're gonna be at like 2.3 when we do that clinic. Okay, all right. Tell me about the Alpine helipad. I haven't heard about that. And why do we need an Alpine helipad is my question. Because we have a helipad within a quarter of a mile.
Mr. Chair, I would defer that question to Tori. She knows a lot more about it than I do,
Okay,
but I'd be happy to have it.
please, Dory, would you?
Do you want me to stand up or?
No, I think I'll let admin sit at the table.
Okay, all right, yeah, so the helipad, it was been a discussion since we, built Alpine in general. And now with, we have been monitoring volumes in our ED up there, our transfer. There is the air park that we originally planned to use, but that does take resources out of EMS to help transport that patient back and forth. And then if we have a landing on a public road, that takes out our enforcement, which also is shorthanded. So it was,
Okay, go ahead.
yeah, it was determined that having it on site would be best and take the least amount of resources from the community in order to have it. Originally, we did think it was going to be an issue with the HOA, but they have since said that they are happy with it. Correct?
Yes.
The HOA has said that they're happy with this.
They're actually very supportive that needed to have a helipad.
Are they all over 65 or something down there?
So from our ER
So-
providers, this has been amazing.
So won't that take up quite a bit of our extra land down there that we would have for building?
Mr. Chair, it takes a 100 by 100 square foot, 100 by 100 foot square piece of property. To the pad itself is 60 by 60, and then there's a 40-foot buffer around the 60 by 60 pad.
It's only a 40-foot setback from all other structures, buildings, or cars?
There are setbacks,
Okay.
but it's just another buffer zone beyond the 60 by 60 concrete pad. Then there's lighting and of course in Alpine with the amount of snow that we get, we feel like it would be really wise to put heated concrete from a sidewalk from the garage out to the helipad with some cost, but it's certainly going to be a lot safer.
That's in the 500,000, a heated helipad?
Yes, that would be included in that. Yes.
Well, I'd love to see those numbers, I guess.
We have not gotten definitive numbers. That's
Okay.
just an estimate.
An estimate budget, okay?
Right now, there is a need for a temporary helipad. And I think we have some of our parking area west of the facility that can be converted into a temporary helipad without much issue, without any construction, really, maybe painting a few lines on the asphalt that we can use temporarily until such time as the board approves moving forward with the helipad.
So what's FAA requirements?
if we have a temporary helipad for less than 12 months, there are no FAA requirements.
No flight
It
pattern,
has, it
nothing?
can only be used a certain number of times, which we're pretty sure we fit under the number of flights that there's a threshold on. But we would eventually go to the FAA and get permission for the permanent helipad that would, we find, get all the approvals we need. And we base a lot of that off of the helipad we have here in Afton, which is, and it's relatively close to the building, but it does meet FAA standards. And so we feel like we have plenty of room down in Alpine. We're gonna have to relocate a few trees to make it work, that we planted a few years ago. But we will relocate those and beautify the area so that the neighborhood is happy with it.
So our numbers, our emergency numbers are that high that we're flying people out of here, out of Alpine?
Yes, they are.
I guess I'd like to see the backing of that. I just am surprised that in the middle of the winter that we've had that much activity down there. We just talked about combining services down there and doctors. And so something's, doesn't add up to me there. I guess I'd like to see some numbers.
Mr. Chair, I think Tori could probably address the numbers a little bit, but we're quite surprised at the activity of ER, the acuity of the activity of ER.
Really?
Yeah.
If you look over the past, if I may, the pace report I keep each day, you look over the past several months, it's at 8.9, 9.2, the last couple of
Per
months.
day?
Per day.
In the ER?
Through the ER. Now it's past 11
Wow.
average per day.
And
No, just in combined, the combined, so it means we added.
Afton and Alpine?
Afton alone has never been that.
Well, go ahead, Tori, you have a comment. And I'm looking for this stuff by next meeting. It doesn't have to be today.
No, I'm happy. And yes, to your point of combining services, as a management team, we have come together and said, yeah, we've been open for 4 months, right? We need to see what summer brings, which is the majority of the patients up there, especially from Star Valley Ranch.
Good thought.
And we have seen that increase in May. So for example, the last 4 days, we've had 7 patients each day in Alpine. We have had multiple transfers. We have had air transfers.
7 a day. Really?
Yep. Well, it was a holiday weekend, but
It was
last 4
wild,
days.
stupid weekend.
The wild, stupid
I
people.
heard ambulances and fire trucks all weekend.
That's for sure.
Yeah.
Glenn, go ahead.
So you brought up a question when you said Star Valley Ranch. What is the protocol? Like, where do you peel off and go to Alpine? Where do you peel off and come to Afton? Who decides that? And
Mr. Chair, may I answer?
Please.
So there is a mile marker, and I can pull it up if you give me just a second to my email. Per regulation, you do have to go to the closest facility that can treat that issue. So if it's a trauma that requires general surgery, first they have to come down here. But for most things, they will go. And I'll give you that mile marker, but it actually is more south than you would anticipate. And so we have taken all of that into consideration with the call volume for EMS. Trying to monitor what our volumes will be like in Afton. We do have that mile marker, and EMS is aware and monitor.
So is that kind of north of Thane, that mile marker? I just.
I'll pull it up.
It's before you get to Sawmill Road.
Before Cedar Creek, right, the Sawmill Road. There is no Sawmill Road, Mike. It's Cedar Creek.
Sorry.
And Glenn.
follow-up question. From my experience with the search and rescue, usually when we load on a helicopter, oftentimes they go to Idaho. Is there this helipad? Do you see it? I mean, I know it'll be used for both, but primarily for bringing a bird in to get patients out or to receive helicopters from accidents coming in. Does that make sense? Because I know a lot of them, those they seem to be affiliated with, well, we're taking them to Ermac or we're taking them out of Pocatello. Like,
may answer. It would be
Yes.
taking them out, especially from the Alpine location. So we had 2 different trauma designations, and that would be a lower trauma designation.
So would they bring some here because of that different trauma designation? I mean, we're a step up, I guess, from Alpine, or not?
This location.
This location
Yeah.
is,
After
but
SVH.
typically they're gonna be transported to Ermac, probably. Or
Primaries, University of Utah.
St. John's, are they in that realm? They're like we are? Okay. And so what does it take us, I guess, and you can give me more data next time, I guess I'm a little, dubious yet, I guess, of this expenditure, although I don't mind having it in the budget. I assume we're gonna look at it some more from your comments, make sure it really fits. It's gotta be a 5-minute transport down to, Alpine Air Park? Base, FBO, where the helicopter lands? Or less?
The distance isn't necessarily the whole lot. It's the loading of the patient, unloading of the patient, getting them situated in the helicopter.
You gotta load them twice, right? You gotta get them in an ambulance and then you gotta get them in a helicopter.
EMS out. Yeah. And that would still occur, obviously. That happens down here with Dixon, but we use Dixon much less frequently.
And EMS is that busy? I mean, we heard today that we can't even keep up with it all, but I haven't seen that many calls.
I think I can answer that, Mr. Chair. So we are always busier in the summer, of course. So it starts about now and it will get busy until probably the end of September, middle of October. But over the year, if you average out the year, the average is about 3 calls per day, which I think the challenge is exactly what's been mentioned here earlier, is that it's when all those calls come on the same day that it just is disrupted and can be a challenge for us. And so anytime we have EMS doing transfers from the ER to the air park, it takes them away from being able to potentially cover 911 and so.
Clint,
Mr. Chair, just statement, you guys can correct this if it's wrong, but I look at this as an investment in patient care. You know, a lot of the things that we decide on are revenue based, and we make money. And this one's truly what's best for the patient. Is how I'm seeing it.
Abby,
I agree with Clint, and playing off that hidden expense, I think we should plan for, but I'm curious as to some input as to why we would want to do it in this fiscal year, given that we would have the FFA 12-month opportunity to have an interim one with the asphalt we already have. Is that a really negative thing in your opinion? Like if it was me running my business, I would definitely plan for it, and I would plan for it in the fiscal year that wasn't. I would definitely do it.
you're saying we've got 12 months to
We have
deal
12
with
months.
FAA. so
Can
why
somebody
not put
give
it
me
next
a,
year?
strong reason why we wouldn't utilize that 12 months
I
and
think,
get it a different financial?
I think when we discuss in June, with obviously some other input on that, and I think we can put some safety valves on our capital expenditures in the sense of saying, hey, we want to hear back about this one before we, I mean, it's not fully authorized.
Yeah,
It's in our budget.
that one I
If it
got.
makes sense, we'll do it, but if it doesn't make sense, and it makes sense to hold off for the next year.
Yeah.
Or my guess is we've underestimated by 50%, we'll need another 500 next year.
That's a good question.
And then
I
my
feel like-
only other question, Mike, and Mike hears this a lot. Can we put it over those big drains? Can we have an elevated one? We still have the hole in the ground for the drainage that is rarely used because it percolates. Just wild, out of the left field remark.
No, I appreciate that. I thank you for mentioning that. We actually intend to fill in specifically the first one we fill in will be the west side drain field.
Yep.
and create more parking over there because we already see that we lack parking right now. So we'll put in a drain field on that west side and turn that into employee parking. Probably not asphalted initially to cut down on costs, but we do need some additional employee parking. So with that, the helipad, it's a good spot that we've kind of picked out because it's close to the doors of the ER. We don't want to have it too far away from the ER itself. So we feel like we're, you know, if you look at Athens and how it's situated, this one is in a much better situation than the one here in Athens. So we do intend to do those things that you mentioned.
So that'd be more of a French drain now than a
Yes.
big hole.
Right.
I'm just concerned with future building. You only buy land in small ones. And it's gonna be way expensive to expand down there, in my opinion, and I'm just wondering if a helipad's more important than a future building, but maybe it is for now. Sorry, you had a question.
Yeah, in my research, I actually don't have the mile marker. I will give it to you. I'll send it over. But the information I do have that I think is pertinent to this discussion is that from May 1st of 2024 last year to September 30th of 2024, based off that mile marker, which isn't listed as this email, this is from EMS, we had 153 patients that came to Acton ER that would otherwise now go. And then to Scott's point, we have had a net gain since the second month in of ER patients across the board, meaning we are capturing more. When I say net gain, I'm saying people who have never been to Acton. Well, I shouldn't say never, but you know what I'm saying. The net gain across
They went down the
board
canyon.
that we are capturing in Alpine. So we had the 153 that we knew, or last year, looking back, would go to Alpine plus we.
If you would find out some more of those details for our next meeting, and Trevor, hopefully we can have a response on some of the questions that Mackenzie, did I say her name right? Brought up. I would like to read. I'd like to hear that report next month too. Those were some interesting statements I'd like to fact check. Abby?
And just out of curiosity, because we were talking about the transport situation, what's determining when people land in Alpine and then they get transported to Aspen? Somebody was telling me that happens quite a bit. Somebody that's definitely knowledgeable.
Hey, Ursula,
Yes.
Please.
are you meaning,
Do we get them stabilized there? Yeah, they make the mile marker decision and then we'll go to Alpine. And then do we stabilize them and then we make the decision to transport them to Athens? Does that happen?
so if any of them need admitted, they come here, right? So we have had a lot of discussion with the ER providers, EMS involved. We do have a guideline in essence that they can follow to try to capture the best location. But those may be walk-ins, right? They may
Understood.
not think that they're going to be admitted and they need observation, so they will. We don't have any obs beds or admission.
So before we go any further, let me correct something that I just said. Dan, I'd like to see those reports. I can't, I can ask your staff, but I need to make sure protocol here is we'd like to have some more of those reports next month, but it ought to go through you and not me directly to Trevor and me directly to Torrance.
So the finance committee in June will be specifically going through EMS.
Great.
And we can include the Alpine emergency on top of that.
Okay. Sorry, I blew the protocol, but I'll learn.
That's all right. You're good.
Okay. Any other question on capital? Did you have anything else, Mindy, besides camera? Anybody else? Hang on. Jeff, I see your hand up, excuse me. Oh, go ahead.
No, I didn't.
Oh, you didn't? Sorry, I was trying to get my computer.
You really don't look out the side.
You're exactly right, not very well. Not very well. I used to. But I don't anymore. You're right. Where was the, hang on, I lost it all. Anybody have any other questions on our capital budget? Again, it's a consensus item at this point. We'll talk more detail I think Dan does have a report on Diamondville. Maybe some things will come up there. Yes, Mindy.
I did have one question. So we have on here Alpine Clinic, and then we have Alpine helipad. So that's 900,000 total. So what's the 400,000 for Alpine?
But, yeah,
Everybody have a,
where is
well, I mean, it
that?
just barely got finished. I just don't know what the 400.
Alpine Lab,
No, it says Alpine Clinic.
Hold on, just a second.
third one. Oh, Alpine Clinic, thank you, 400. And then, okay,
It's just a question. I
the
guess.
equipment, I would assume that's some kind of equipment.
The new X-ray. Unit moving in and,
Correct. It's the replacement and remodel of the X-ray unit and room that we put on hold a month or so ago. We decided to put it on hold, and we budget for it again next year.
Thank you.
I think more than half of that is.
So I have a question on the layout here. So the first sheet is our projection for total, 6.3. We got 3.8 for routine capital and then another 2.5. And total proposed capital outlay. And then we have some other sheets. Those are line items.
Those are more line items. It's within 50,000, I think.
So that 400, if I just saw one for Alpine, it was like 25,000 for something, or was it, building improvements? That's part of that 400 then? You summarized these line items into that total. Okay.
This is more rationalization that, you know, today we got 2 more requests that came in and a final sweep of requests. So we'll be rationalizing this a little bit more in the next couple of weeks with, you know, the list, if you will. And then, you know, that final list will be submitted to y'all for detail and some fund. If you'll note on that, I noted that the biggest one is maintenance. We have an aging facility, and the maintenance line items alone are just, a lot of them were pushed to this year, from last year. This one just obvious there, but that's the largest.
Okay.
I mean, the roof is the biggest one for that too. right?
Any other questions on that? I think we can get that sent on. Moving on, Abby, I think, quality subcommittee gives her report.
Referring to Mindy, as she said in on that.
We had a meeting yesterday and it was really quick. I think we had 20 minutes total. So just, show a lot of stuff going on. People are doing good with their reports, medication errors, falls. I think it had 0 falls for the last couple months. Everybody's reporting and I think doing good. So Sadie, did you have any additional stuff?
All right.
Thank you.
Compliance and technology. When are we starting that, Mr. Chris? I know that's
Mr.
your
Chairman.
chair. Do you know when we're starting?
Yes, so June 27th, 19th, sorry. June 19th, we're gonna start that first meeting and we'll have it at 8 o'clock. It's a Thursday. We'll have it at 8 o'clock in the morning.
Okay, on a Thursday.
And that will be our first meeting,
Okay.
Is that all we do?
right?
I was gonna ask who all is, right now. I
The
just have
question
the-
is, I recall
I
that
think
was-
Mindy's the chair.
Mindy's the chair, and I think Jeff and I are on that.
Oh, okay,
Is that correct, Ann?
okay.
Foundation report is, Jeff. Do you attend any of that?
Foundation.
There was no foundation meeting in May. Okay.
No, wait.
Yeah,
There was, I think.
it says you.
I think you the auxiliary.
It was me. Yes, that was.
Oh,
the
there
meeting.
was one that I was supposed to be. I have
Nope,
no
you
idea.
weren't.
You're on the agenda, but I think it's
It
Abby.
was me. I was there and it was a good meeting. Some changes with Mark Taylor leaving and some decisions to be made on that structure. And then the biggest thing they talked about was spending money above $10,000 without foundation consent. So they retroactively approved some.
This will be the foundation board.
Yeah.
Okay.
Yes, that's my report.
Okay. Auxiliary, do you have were you at that one?
I was at that, yes.
Did report on our auxiliary?
That's for me. That is a great group of girls and, they.
No guys?
No, there's no guys. Dan's the only guy there.
Feel special.
He was invited to this,
I was thinking, Mr. Reinhardt used to be,
There are a few auxiliary.
just weren't there that week, okay. Go ahead.
my report is that, they're actively gearing up to help with the golf classes and the, half marathon. And they're doing some big raffle items that we spread about the community, so it's good exposure and they're up to good business, so. People are so inclined to buy raffle tickets. You know, hit up your favorite lady because there's an extra prize in store.
Okay. Under medical staff bylaws change, we have a motion to approve, and I think is what we need. Is that correct, Andrew?
Make a motion that we approve the medical staff bylaws page.
Well, let's discuss.
Yes, yeah.
Second.
So it's moved by Mindy and seconded by Jeff that we approve medical staff bylaws change on qualifications for resident affiliation as presented earlier in the meeting. Any discussion? All those in favor? Any opposed? Okay. Board policy on public comments you have in your packet. We can ask Brandon comments if we want. Here is a proposed policy. So what's gone on is we really haven't had a policy. So as I looked at this and got with Brandon and Dan, we thought it ought to be put in a policy like many of the other boards. School board locally has one, I know. County commissioners have one. We try to hold to that. And so do you have any thoughts or comments? Basically, there'll be a forum. If you want to appear before us, you'll make a written request 7 days prior. I'm going to paraphrase here. It'll have some certain requirements, mostly just name and what you're going to talk to us about. They'll need to be in, that's the timely request, it's the 7 days. We're going to allow, and this is a draft, by the way, we've got in there 5 minutes to speak. And speakers can't yield their time to others. We can't have a filibuster going on. Time limit, okay, total comment period, we're suggesting maybe 30 minutes, may not be that long, it could be that long. Notice some have stayed, but we lost a lot of our public too tonight. It must have gotten boring. Then I've talked about conduct and decorum. Basically, it's just be nice in the sandbox and treat everybody nice. Board discretion, we can discontinue public comment, which violates the policy. Reserves the right to refuse to place individual topics on the agenda. Falls outside the scope of the district's jurisdiction or otherwise inappropriate for discussion at a public meeting. Board may modify or suspend this policy in respect to special circumstances or upon majority vote. Any thoughts or comments? Do we want a policy? If we want a policy, is this one anywhere close to what you'd like to have? Or does it need to be amended? So I think the first question is a consensus of whether we want a policy. I don't need a motion on that. I'm just wondering, that's why this is brought up. Do we need a policy? Do we not need a policy? Board.
I think your policy is great, for no other reason, communicating to the public, how to engage.
How to engage? Okay, at a public meeting, you can always engage us. Right.
I see it as a way that we're inviting them to have comments. I don't know if it's clear to me. They just have something they want to say, they just present it to you, and you decide if it makes it onto the roster or not.
Yeah, I get to control the agenda, yes.
You'll make that decision.
Isn't that correct? You know, I don't know why I would not allow
Or
something.
the chair reserves the right to
They allow me on the agenda, so I allow everybody else.
Once in a Would have to, by nature, select.
We'd either select or reduce their time to 2 minutes.
Yeah, so
Or 3 minutes.
A question,
Go ahead.
just how would you intend to enforce the time limit?
Good
Is there
question.
a timer?
Andrea has an answer to that, I think.
We would have a timer that someone would display.
Did we think that we could put it on the screen? Weren't we thinking it could be a timer on the screen?
We could. The only thing is if we show that on the screen, if someone is speaking, they won't be recorded. It will show the timer.
Gotcha.
So
We'll have a different timer because we want to record everybody. Brandon, do you have a comment or question?
I just was gonna note that in item 4, it says that it's allocated for 30 minutes. So you could either limit it to 6 people, or as you suggested, you could say, well, we've got 10 people that want to speak today, so we're going to limit to 2 minutes. So to give kind of some flexibility, if there's a time where there are a lot of people that want to be heard, then, you may limit it to a minute each. And then, the other piece of this too, right, is to limit duplicative comments, right? There's no need for the board to sit here and listen to 5 people in a row, take 5 minutes telling you the same thing, right? And so this allows, you some discretion in that to say, okay, the form that I have attached on the 3rd page, helps determine what the subject would be and potentially grouping some of those together, so.
I would suggest just editing that wording to let people know if it's duplicative, that it would be synthesized, or that you could reduce it from 5 minutes based on the number of people who want to comment. That would be helpful for somebody to know in advance.
It's in this, isn't it already? Item,
The reduced minutes is, but.
the chair may adjust individual time limits proportionally to ensure all approved speakers are heard within the 30-minute time period. We could also extend the 30-minute time period, I think. Isn't that right? If we chose to.
By a majority vote, you can suspend these rules or.
So it gives us a fair amount of flexibility, but we have some guidelines and decorum, so. Is there anybody that's really opposed to having a policy? Then I'm open for a motion to approve as is. We can always change it later if we find it's not adequate, or do you want to amend anything?
Quick question, will the
Yes,
agenda
Abby.
be out before the 7 days advance notice? Because I think it's the agenda that's gonna spark people being like, oh, I want to comment on that. It's my opinion, but,
The agenda doesn't usually go out to the public.
okay, so it'll be something from previous months or days or something.
Or if they feel, they wake up that morning and say, I really want to be on the board agenda, they can, 7 days ahead, they can call in.
All right, it
And
seems reasonable.
I'm sure we can accept this by email or fax, or not fax, anymore, but anyway, emails and pictures on text. There's lots of ways to accept these forms, I think. They don't have to bring them in personally. Okay. Clint?
Mr. Chair, I make a motion to approve the North Lincoln County Hospital District comment policy
As written.
as written.
Second.
Motion by Clint to approve the new board policy on public comment. And seconded by Mindy. Any further discussion? And that would also include with it the attachment that is the request as written. Okay. All those in favor?
Aye.
Any opposed? Okay, that passes, Sandra. Broadcasting and recording minutes. So you heard me at the beginning of the meeting indicate that we were recording this meeting mainly as a test. I wanted to bring it before the board to find out whether or not you want it recorded. Every board I know is different. The town of Alpine You can tune in and watch every planning and zoning meeting and every town council meeting if you so desire. Or if you go to the county commissioners meeting once a month, they do not allow you to zoom in. You have to go to a specific site, as Brandon mentioned. Planning and zoning in the county is the same way. The town of Afton allows zooming in, but you gotta get prior permission from the administrator and she lets you in. So everybody has a little different. There are probably some boards that don't do it. I don't think we're required to zoom it. We're here and they can come here. It's public meeting. So do we want a policy is the first thing, and if so, again, we okay with the way this one?
Mr. Chairman.
Well, there's no policy on that,
Policy,
excuse me.
just
This is
the,
just,
a motion
do we
to-
want to do that? Anybody opposed to recording? Does anybody feel like they wouldn't say the same things if a meeting's recorded, being watched by the state of Wyoming?
Want a motion?
No, I don't think do we need a motion?
I mean, I don't think it hurts to.
Yeah, let's have a
To
motion.
move it. It doesn't need to be by formal resolution.
Yeah, we don't need a
policy, but
resolution.
We
Let's
need a motion.
I to record board meetings and make them
Okay.
public.
And yeah, that is, we would then post them on our website so that they're archived. Watch many times. Clint?
And I make an
Amended.
Friendly amendment?
that we come up with a policy stating how we're going to, like, there's differing, the county makes you go to a place. These guys allow you to Zoom, these guys don't. I think we need a policy of how we're going to, I agree with we need to do it, but we need a policy as to how
I would love, we posted on our website, the dates, and I would love the link to be adjacent to those dates, very accessible.
So should we have you prepare a resolution for the next meeting
Sure, yeah, or.
that clarifies what our discussion is
Sure.
today?
And one of the questions that I would have too for you as I prepare that, do you want it to be Zoom style, whether it's Teams or Zoom or, that people can join and participate, or would you prefer, it to be like I think
Listen,
school board meetings are streamed live on YouTube. And so there's just a link to the YouTube channel and that you can monitor, you don't.
I think it's,
Yeah.
I think
That's
it's
what we
listen
do.
only. I
That's what
think
I
it would be hard to scroll. Sandra,
how we're gonna do it.
We got Teams technology,
That's the one.
and we would record it on Teams, they could participate on Teams, we would have the link. And then we have a YouTube account, we don't have the hardware right now to stream it on YouTube. But then the link would be on the webpage.
So we'd link it so that they could see it on Teams. Then we would archive it in YouTube, is what I'm hearing you say. IT, is that? Assume that's who she's pointing to.
Well, the teams require them to be a Valley Health Employee, or the whole community could link with the teams.
Anybody that had a team is that,
1,000 people could be on the Teams.
but it would be listen only,
They
no
Yes.
questions, no
can- So
hands,
they
no,
would come in,
no photos, I don't know. Names only.
we have set to, so that anybody who comes into the meeting, their microphones turned off and their camera.
Mr. Chair, I guess that's the question. I know on our policy that we just had for public comment, do we clarify that that isn't in person, that it would be stated,
Yeah.
the teams or remote?
Would you add that and bring that one back to next meeting also? Or just approve?
Comments have to be in person.
Yeah.
Yeah, and that's what I was gonna say, we have the 7-day lead to ask a question, so there would be no reason to authorize commenting from the team.
Good point. So we'll review an amended policy next month.
Mr. Chairman, I mean,
Yeah,
I would
go ahead.
feel comfortable if you wanted to just
Amend
the
it right now?
policy now to reflect that.
You want to make a motion, Jeff or Abby?
I'll make a motion that we amend it so that, to clarify that,
Okay,
those wishing to comment need to be present in person.
okay, and you're seconding, Abby?
Second, yeah.
We got a first and a second. Any further discussion on amending the public comment policy? All those in favor? All those opposed? Okay. Back to the next one is the resolution for document requests. So what we have, go ahead. Do you have something?
Were you going to have a final vote on the broadcasting and recording,
Oh, that's right.
Mr. Chairman?
We went back and
He
amended.
amended it,
But we
and
never
now we're
voted.
going to vote on it.
No, the amendment,
Well, the amendments for the previous one,
The amendment was
for
for
the public
the public
comments,
comment.
but we still need the motion on the.
oh, we didn't actually finish the vote, sorry.
Was somebody taking it?
So we need a motion on broadcasting and recording. Clint? You asked
He
me.
gonna come up with a policy for him.
Well, that's right. We asked him to get a policy, so we weren't gonna vote this time.
So you-
We will record it next time. Isn't that right?
Sure.
We were gonna
And
have-
you can still proceed to, to. still-
Yeah, we're gonna,
You did this-
we're gonna record it in June. And, but we'll have the policy in front of us in June to look at for specific wording. Okay? All right. Moving on.
So quick question.
Yes, question.
Will this be made available?
This will be archived on our website, this is my understanding.
So is anybody got a second motion to amend the motion?
I'll second.
Which motion was that?
So
Have you come up with a policy?
Abby
Oh,
made a
Abby.
motion to proceed with recording and broadcasting the meeting. It technically failed for lack of second, because it can't be amended
Amended,
without
seconded.
being seconded, so it failed for lack of second.
Clint made
Keep
that.
it great.
Moved to develop a policy, which that could use a second.
Okay, and Abby,
Seconded that.
seconded that, and all in favor?
Aye.
Okay, we're gonna get a policy out of it, right? Okay. Keep me straight. All right, now we're at documents. Public records. And, here's my thoughts on it. You read basically, it agree that we need to provide them, but at what cost? Now, my thinking is if it's a minimum, we're not gonna charge anybody. But if it's a huge review of documents, we're gonna charge. And what I'm suggesting here, I'd like to change it. And here's my reasoning. I called Trevor and I said, so what are our costs in some of these areas? What are our average costs? I didn't get anybody specific, just average cost. And so I suggested, but it was after, and this was produced to you guys, 35 for clerical. That's per hour. 35 for IT. And there was another one for executive staff would be 90. That would be administration. And outside professional, like attorneys, would be 150. And I looked at standard attorney charges and kind of said, what if we split it 50-50? I don't know that the taxpayer ought to put the whole bill. Maybe we pay about half of it and they pay half of it. The other two are closer to our staff. It isn't the full cost of what a staff is. I didn't take into account, benefits and different things. This is more just straight wage. I felt, and what the statute talks about is reasonable. That's what I'm gearing into. I think that's arguably reasonable. We could, if we were taking the task, we could say, hey, this is reasonable. Medicare reimburses this at cost or a little bit less than cost, right? So taking a government stance here. Anyway, that's my thinking, and that's what I would like to propose is 35 for clerical, 35 on IT, add a line number 3 and cross out or make 3, 4 and 4, 5. Number 3 would be $90 for executive staff. Yes,
Mr. Chair,
Brandon.
just to clarify for the rest of the board, so this would be for preparation for those, to produce what documents are being requested, right? So if someone comes in and says, we want
all of these documents from this period to this period. And, for clerical, clerical staff will go through and pull those. We're going to, log that at their hourly rate. If there's an instance where we need to be involved, obviously we would do it at our hourly rate. And so this would pass those costs on to the requester, to some degree, right? As you mentioned, it wouldn't be all of the costs, it'd be the costs as out.
Yeah, so, and then there's costs for printing and that I think are all, pretty reasonable. So my question, I guess, Brandon, is, so, if somebody calls Andrew up and says, I'd like a copy of the minutes, when do we decide that we don't need to charge? I mean, how do we state that, I guess? Because that's, some of these minor things, I know she does a wonderful job and it's gonna take some of the time. But, if it takes her over 30 minutes, maybe we ought to have if this is a task that's gonna take 30 minutes or an hour or more, maybe that's where we start a charge. Anything under 30 minutes, or, I don't know, I'm just throwing out an idea of numbers. I think there ought to be a cutoff because there's a lot of things that are pretty simple. We can shift to Jeff first and then that.
Is it maybe better instead of the time to talk about what type of information? So for example, the minutes of the meeting, maybe we, the recording and perhaps a copy on the webpage. You can pull your own stuff.
So you're thinking put the minutes on the webpage also, okay?
And then that would just be accessible by anybody at their own cost to print or whatever. But if there's any request, it doesn't matter what the time is, they're gonna start scheduling. Now you're forcing it on the staff part.
Okay, so we would put, our board minutes on the website. Don't really have any problem with that. Anybody have any problem with that?
I like it.
Abby, you had a question, though?
It wasn't a question. I listened to the training you asked us to listen to. I'm pretty sure we printed and have it in a binder physically. Is that true? Our minutes? Not true. Yeah, we already have that. So when you have a public record request, when you already have it printed, you've already set the standard. So it's to the what Jeff's saying. This is definitely
So
more
what
like
you're-
a deep dive is being asked for.
So Andrew already has it in a folder. You can walk in and ask her or have her email it to you right now.
Right in a second.
And
Not a bad idea to put it on the website, but it's not.
Or you could have a policy that says certain things will be provided free of charge, but you could also have a policy that says under a certain dollar amount, you'll provide it without charge. So for example, the town of Saratoga has threshold of like $180. Less than that, they're not gonna pay. How they pick that number, I don't know. You could pick a different number. So you could do that as well.
so you could say anything less than $35,
Sure, yeah, could set it.
which is an hour's worth of work, basically, on typical things.
Basically making them synthesize their request down to what pertinent information they're looking for.
If they're gonna cause us to go to a lot of effort, I don't
Yeah,
have a
but
problem.
not
They can
that
have all the
information.
public documents they want, but I don't think the taxpayers ought to pay for it.
So, I think one of the issues you're going to have is, in the requester's mind, they may not think it's an hour's worth of work. And so,
They're gonna have to trust us.
well, I'm just saying that's one of the things that you're gonna have to come up at some point, right?
Well, here's how that works, is when they come to get it, or before we mail it, they give us a check and we give them the document.
I understand that. I'm just saying public perception, saying, hey, some things should be, some things shouldn't be. I think we just need to make sure that on our side, we're covering our bases to make sure that we're making it as,
Easy on the
easy,
people doing it.
easily accessible as possible. For example, the minutes, that type of thing. So we know that.
We can make
If
sure
there's
that
other
things are
things-
easy.
There's
I
other
don't
things-
disagree, but, I mean, I'm in a business that charges by the hour, and they gotta trust me. And if they don't, then they gotta hire somebody else. And it's just kind of the way it is, and I think I give more than I did, and I think Andrew will be the same, is we're not gonna be overcharging. But
And I asked clarification from you, Brandon. If somebody requests records, we have 7 days to respond. That's true.
To say that we
We will.
received it.
To acknowledge.
To acknowledge and in that conversation would you maybe make some assessment as to how labor intensive that request is going to be?
Right, so
Is that what standard procedure is? What I'm asking.
in the resolution, it says that they'll prepay the fees. And so that would be how it would typically be handled is during that 7-day period, that you can acknowledge it, you would determine your best estimate on how many hours you're going to require and if, let's say, it's they'll prepay. And if we reach that limit, we'll provide them with the documents that we have and say, it took longer than we anticipated. Here's the documents for the amount that you prepaid.
Yeah.
This is what we estimate would require to get you the rest of the documents.
A lot of things are gonna be easy, but if we have to go through the emails or other documents and redact things, and we have to hire our attorneys to tell us what's public information and what's executive or personal information.
Yeah.
That could take a while. Thoughts, comments, how it's, so my changes were to items 1 through 4 and adding a 5th. Yeah, and, other comments, thoughts, or we have a motion?
I wanted to, this is the policy that all public entities have. They do have fee schedules. We just haven't had one in the past. So
And the statutes allow us to have that.
Yeah, I
It
think
says
they're
it needs to be a
necessary.
reasonable cut.
I agree.
That's-
I worry that the way the public will twist this is that we're trying to stop and not put information out there, but I just want to be very clear. It's definitely within the law of the state. This is something we
Yes.
should have had in the past. We're rectifying that. Now,
We
as
just
to
haven't had a
anybody
lot
who's
of requests.
requested records previous to this going into effect, you might have to address that specific situation separately.
We can change this if it needs to be changed. I mean, this is amendable by the board at any point in time. This is kind of a starting place in my mind to try it out. And I think as we go forward, and I don't think there's ever been a decision that I'm aware of that we haven't been just totally transparent in the 15 years I've been on this board. But as we go forward, people are looking at it more and more.
Yeah, and it's
They
great.
want it.
This stuff is recorded now, and so versus looking through paperwork, I think we're gonna save ourselves a lot of time. Recording's done for all that transparency.
One
So-
change before I sign these, would you put my initial A in the middle? Because I can't sign without it, just to have it. Thank you.
Did we need a motion here?
We do need a motion on this, resolution number 2025-08.
As amended.
As amended, unless you don't like my changes.
So briefly, excuse me,
Go ahead.
just to reiterate what those changes are, so I get them
My
right.
changes were number 1, clerical staff would be 35. Number 2, IT staff would be 35. A new number 3 would be 90 per hour for executive staff. Item 3 would become item 4, which is 150 per hour for outside. I want to add the word outside professional staff.
You just want to just hold it. New number 3
Yes.
is what?
Sorry, Andrew, I've got all of them.
You have them all?
Yeah, sorry.
Okay.
And then number 5 would be what is now 4, actual cost of programming and computer service.
Mr. Chair, I would take into account consideration of physician's time. If there's a request that involves a physician, that is extraordinarily expensive to the organization.
Do we call that executive time at 90, or do we have a 6th item? Is what you're suggesting, a 6th item?
I am.
I have no problem with that. I don't know how many times we're gonna find a doctor that will actually come in and do any of it, but. You can't afford us. I'm recording. Just want you to pass it on to your.
It's on record, baby.
clients. Yes. Linda.
Wouldn't that be included in medical records? Or is this something totally, I mean,
I'm not sure what Dan's
Yeah, me
thinking,
neither.
how a doctor would be involved.
Well, so if, if you're looking at requiring a physician's email or,
Oh.
if you're getting into HIPAA, you're getting into, I mean, you never know what the request is going to be. I'm just saying that if you're asking for a doctor to spend several hours on that only they can help resolve for a document request, it's going to be financially taxing for the organization.
And that gets to the other question then. Do we feel that, so what if it's not a doctor, what if it's not executive IT or clerical? Is there value in another line? Or other, or does clerical fit everybody? Because at some point, somebody's gonna find the loophole, if you will, to ask for somebody else to pull their information for them without a fee.
No, we were required to go through the executive secretary, who is now Andrew.
Okay.
It doesn't go, I mean, they can't just pick and choose who they get to have this done by. We're designating by the policy as to how it happens, and she's going to make a judgment, discussing it with our attorneys and CEO and maybe the board if we need to, but typically, I think those questions will be answered. And she knows what will be needed and what isn't. I know this is new to us, but I think it's also been around. I don't know. That's a good comment, Dan, on medical staff.
What's the name?
Oh. Oh.
I think we're gonna lose money having doctors do it no matter what, so we pick, and even with executive staff. I mean, I don't think we're gonna collect everything we get. Yes,
Chairman, I
maybe.
say we do it the same as the professional staff, 150 an hour.
Okay,
That's my,
anybody have any other, I don't have a problem with that, let's start there and see what happens. See how many times we need to use those doctors.
and if we need to raise it later, we always could.
So you would add a line or just include medical staff as executive or as professional? So we wouldn't want to say outside professional. I think we ought to have another line to say medical staff. Is that the right word? Provider?
Yeah, medical staff's gonna be a lot higher than that.
It is, but
We're
I
gonna-
understand that, but a lawyer, I mean, he said he went halfway.
One half of a line.
Yeah.
right?
Okay, so do 250.
Let's start there.
Yeah.
Anybody have a problem with that? Okay, so the amendment then is adding a sixth line item. Prior or after executive staff and before outside professionals, the medical staff. At 250. Randy, you got all that? So you can make sure she has it. So did we get to a motion? Okay, Dan made a comment, okay. Do I have a motion?
Can you,
Yes, Abby.
in my notes in here where you kind of said, well, if it's under an hour, we do it for $335 or what was that all about? Does that feel like it needs to be in there?
Yeah, let's,
The first $35 is waived. Like if it's a simple request.
Yep. Sounds
Somebody
good.
said this, I'm just clarifying.
First hour's waived.
First hour of
Services.
meeting time,
Right.
because
No, it's not an hour, it's $35 fee. So like if you use a document,
Yeah, there
you
you
did it
go.
for 10 minutes.
First $35 is waived. The discount.
Basically, if you can synthesize your request instead of just like then, great.
Or
Why don't you just say if it's underneath an hour or underneath?
because
We could do it like
But
200.
it needs to be less than $35, right?
and the way he's gonna word it,
Less
it's gonna
than
be the
versus-
first 35 is free.
you're gonna go 35, or you're gonna go less than 35.
Well,
If it's an hourly rate, I spend a half an hour on it.
no, it's not an
Not the
hourly
hourly
rate,
rate.
it's a fixed number. Is what Dale suggested, right? Is that,
For
It could
instance,
be.
if the IT need to do my request and it takes them an hour, then I'm not owed $15. Or $35 a day. Their fee was- But I would let them know when
adjusted,
in that 7-day window.
adjusted to our 35, though, so it was 0. Our IT, I suggested 35.
Yeah, this is, yeah, whatever.
It's the same
the
idea.
deadline was.
So I think we're using
First
$35 discounted. However you want to put that, Brandon.
Okay.
We ready for a motion?
Make a motion that we adopt the fee schedule for public record requests as
So it's the resolution number 2025-8, I believe. On the first page, it's the whole resolution, including the fee schedule.
Oh, okay, thank you. Yeah, I'll make a motion that we adopt the resolution 2025-08 as amended.
I second.
We have a motion by Jeff, second by Clint. We approve resolution number 2025-08. Any more discussion? All those in favor?
Aye.
Any opposed? Okay, we're ready for, our CEO's report.
Thank you, Mr. Chair. I made this available in your board. I'll also be, after the board meeting, we'll send this CEO report out to employees as well as the medical staff, so they have a copy of it, just to see how we are, we've done over the last 60 days with our action plans. I won't touch on everything just for the sake of time because it is in writing and but I will touch on the highlights, especially the ones that, we've made commitments to follow up with, and then if there's something that I don't touch on, please, ask me to touch on that particular topic. I do want to point out that as far as the financial, as previously discussed by our external auditors, $7.2 million positive adjustment was made to this fiscal year's net revenue. So through the first 10 months, our EBITDA is 6.8 million, which is exceeding our year-to-date budget by 1.1 million. Increasing cash flow still remains the pivotal issue for the organization as we continue paying off our short-term working capital note, plus the challenges we continually face with procuring payments from insurance companies and some of our patient base. As a footnote, you should know that throughout the industry, right now, insurance companies are facing significant financial challenges, specifically with managed Medicare or Medicare Advantage plans. They're underwater. And so the information that we're seeing in the literature throughout the country is that denial rates on just regular claims from commercial carriers have increased double digit. And that is really hampering the time to collect the cash. So just know that the whole industry throughout the country is experiencing a financial challenge, and the ripple effect is being felt by Star Valley Health, just like every other hospital in the country. Volumes still remain positive. Total outpatient visits are up 11.4% over prior year. Total surgeries are up 2% with 3% growth in a decrease in 1% in inpatient surgeries. As previously mentioned, the Alpine ED is contributing to a 7.4% increase in emergency room visits, and inpatient admissions remain flat year over year, mostly due to diagnosis and acuity in inpatient days. So the working capital note, we anticipate by the end of May, the outstanding balance on this short-term working capital note will be approximately 5.5 million. So we've gone from 11.5 down to 5.5 in just a matter of months. Yep. The APR is approximately 3.5%.
What's APR stand?
And the annual percentage rate.
So it's not the sharks that got us.
No. Okay.
3.5. Can we get that at a local bank? Wouldn't want me 3.5%?
Mr. Chair, can I answer that?
Please.
Come see me tomorrow.
I don't know of a local bank that would give us that rate right now. So that's a good working capital rate. I wanted to point that out.
So hot off the press, Optum Bank has negotiated with us to reduce the holdback from 34% to 20%. Okay, so we're working.
Yeah, we have positive cash flow.
Yeah.
Okay.
Okay, so that's hot off the press, and we feel very bullish about our ability to manage our cash positions as we navigate, this situation. This could prolong us paying completely off the 5.5 million as of the end of May into October, but it gives us that breathing room to address some of the immediate concerns. Okay. Revenue cycle and billing remain our top priorities and will continue to be our top priorities until we have 100% confidence the patient experience is consistent and very positive. As a first step, we will soon be sending out paper statements and bills to patients every 14 days rather than monthly. This will enable patients to get relevant information in their hands more quickly and more consistently. It will also foster earlier discussions between the patient, Star Valley Health, and the patient's insurance company. This change will be implemented as soon as we complete internal testing. Patient communication. We're also making great strides with our teams by proactively reaching out to patients to, one, make them aware of their estimated patient responsibility, and two, how we can best work with them to ease any of their financial concerns or burdens. We talked about days cash on hand, how we've been able to hold it steady at about 60 days. We talked about our days in accounts receivable. To Cole's point, in April, we collected, in March, we collected $9 million. In April, we collected an additional $2 million at $11 million. So our cash collection efforts and our action plans with the revenue cycle are starting to really pay dividends. Upfront and back-end cash collections after implementing tighter upfront cash collection procedures and efforts. April's weekly copay collections are now double what they were in March. 4,000 in March compared to 8,000 in April. That's per week. Our receptionists and front desk personnel deserve high praise for their efforts, and a lot of other folks. On the back end, our partner revenue enterprises completed their second full month of working with self-pay amounts, which is what this patient still owes after insurance amounts have been settled. In March, they collected 529,000. In April, this has increased to 848,000. And revenue enterprises in their last meeting with us, they fully intend that number is going to go up significantly over the next several months. Objective perspective from the outside. Most hospitals try to learn from each other because hospitals face very similar challenges. Ivinson Memorial, located in Laramie, Wyoming, went through an Epic conversion and faced cash collection and revenue cycle issues in their past. Having learned of our recent revenue cycle journey, the current Chief Financial Officer, Jim Bands, has agreed to provide an outside and objective perspective to assess our current billing and collections processes and to help implement his recommended changes. Jim's first on-site visit will be June 12th, and he's already engaged with us, so he's looking at information. Based on the aforementioned information shared in today's report, and as a follow-up to the commitment management made in April's board meeting, we intend to reinstate the employer's contribution to retirement accounts beginning Friday, June 27th, barring any unforeseeable negative financial circumstances. It is also our intention that any employer contribution amounts in arrears over these 3 months will be restored before December 31st of this calendar year. Okay?
Is it actually been 3 months?
It will be in June.
In June? I was thinking that was July, it was 3 months. Okay.
Cigna contract update. We are meeting regularly and communicating with Cigna to resolve both parties' concerns. Last week, we submitted another counteroffer. We're waiting for Cigna's response or a counteroffer from them. Both parties still remain hopeful that we'll reach a positive resolution before the July 1st deadline. The complexities in the negotiation are such that they have to send their, we're talking to the local folks, but they have to send it up a national chain for approval. And so that does stall our ability to get resolution quickly. Town hall summary. I committed to the board that we would hold a town hall meeting on May 8th. We did that through the help of platform and support of telephone town hall meetings. It's a Colorado company with a suite of mass outreach tools used by school districts, municipalities, legislators, advocacy organizations, businesses, and other organizations. We promoted the event to the public through social media, newspaper, advertising, media release, posts on the Star Valley Health website, and digital marketing. Here are the numbers, just so people are interested. 134 people pre-registered for the event. TTHM purchased phone numbers for 4,663 households located in our primary market area, targeting women 30 years of age and older. So it wasn't everything. 33 people submitted questions when they pre-registered. 5 people called in with questions during the event. The maximum people attending the call was 468. About 250 listened to most of the call. There were 210 callers still listening when the call ended. The leadership team is following up on most questions we did not have time to answer on the call. Some individuals commented on social media they did not receive a call to join the event. This may be because 1,551 of the calls dialed were unable to connect. This is a larger than normal number for TTHM. Research showed some local telephone networks were unable to handle the call volumes dialed at that time. If we hold another town hall meeting, which we intend to, TTHM can dial the numbers more slowly to avoid this problem, and we'll experiment with different days of the week and times of the day to increase our capture rate for the community. Dr. Stuckey, so Mindy, this is specifically on this one. Dr. Stuckey and Dr. Brian McClure's practice location in Diamondville. South Lincoln County Hospital District has asked Dr. Stuckey to vacate the office space he has utilized for many years in Kemmer. So he has spent years and years building his practice down in Kemmer. Dr. McClure has not yet been asked to vacate. Many patients in that area of the state are asking for continued access to both of these physicians' expertise and services. In light of the current freeze that we have on capital projects, in order to solve the immediate need for access to care, we want the board to be aware that we will be leasing a temporary mobile unit to be placed on the property we own in Diamondville. Our goal is to have this available for use in late summer of this year. Provider recruitment update. To meet the needs of the community served by Star Valley Health, we are recruiting providers in the following specialties: non-invasive cardiology, otolaryngology or ENT, and pain management. From now through September 2025, providers in the following specialties will begin working for Star Valley Health: 2 emergency room physicians, 1 family medicine physician, and 2 anesthesiologists. Quality and process improvement update. The process improvement projects are progressing with the following updates. Emergency room labs, blood cultures, and peer review are 100% complete and in the monitoring phase. Surgical consents is 90% complete and on track for a go-live date in early June. Procure pay is 80% complete and on track. Software oversight is at 60% completion due to logistical barriers with new hires. GI Quick is 75% complete, but off track due to increased documentation burden for providers. And we're working with the provider clinic staff and OR staff to assist with documentation. So in the organization, process improvement is becoming the name of the game to do more with less resources. And you have to have pristine processes in order for that to happen, which includes, the billing and revenue cycle. Information systems and technology team remain focused on strengthening our security, performance, and resilience, especially in light of the almost every day hospitals being hit by cybersecurity attacks. Ongoing work through virtual local area networks help us to isolate traffic, improve monitoring and access controls, and limit lateral movement should a breach occur. This has required a considerable effort to avoid service interruptions. The clinical informatics team continues to work closely with OCHN to drive down outstanding issues and requests. Department leaders and enterprise system analysts, ESAs, meet with analysts on a regular basis and work toward a transition to maintenance. Finally, nursing and long-term care. Over the past month, acute care nursing staff received charting education provided by our malpractice insurance carrier. It was beneficial training to help educate the team on best charting practices. In addition, nursing leadership has monthly training on different topics. This month was on process improvement strategies to support ongoing operational improvements. We've started drafting department and hospital charters for the Pathway to Excellence designation, a credential through the American Nurses Credentialing Center, ANCC, that recognizes healthcare organizations committed to creating a positive practice environment for nurses. Achieving this designation supports nurse satisfaction, improves retention, and promotes high-quality patient care, aligning with our strategic goals for workforce engagement and clinical excellence. We have not obtained the status yet, but are starting our progress towards it. We're finalizing our annual infection prevention plan for both the care center and the hospital, which we present to the board for approval next month. This month, the care center admitted its first skilled nursing Medicare resident. This allowed the resident to remain in their home for advanced care, typically provided under hospital swing bed status. This model enhances continuity of care, increases the scope of nursing practice, and improves Medicare reimbursement. Lastly, we're currently within the window for our annual care center survey, as well as the hospital, and anticipate a visit from the state survey team imminently. That's our report.
Questions? So Mindy first.
Chairman, can I ask Mr. Cordez?
Yes.
The CEO a question? Okay, for the Dr. Stuckey, Dr. McClure, how often are they, like how many days a week, how many days a month are each of them there? I'm just.
2 weeks out of the month. Two days.
Full week?
No, I'm sorry, 2. So they go down there every other week. There's 2 days that they go down
2 days, so,
Each of them 2 days?
there.
so one of them
Is
goes
that, is
one
that
day a
accurate?
month.
Is that accurate?
And
Jeremy.
yes, so Dr. Stuckey will go down, we've changed the pattern because of the inavailability, that not being available, but Stuckey will go down like once or twice a month, and his PAs will also go down once or twice a month. So I think Stuckey's team would go down Kemper one day a week.
Once a week.
Yes.
And
Okay.
Dr. Brian McClure, I believe, is 2 days a month.
Okay, so my question is, how much are we leasing this building for?
We're right now, our anticipated cost is $3,000, a little over north $3,000 a month. Is that accurate?
North.
So 3,500.
Mr. Chair, can I
Yes.
add some
Yes,
color
please.
to that? So we're in essence gonna rent a double wide. The company will set up for us. We can use it for as many months as we need to, and then when we're done, they'll move it away. And the anticipated cost, of course, we'll have to put utilities into it, water and sewer, electricity. They set up the ramps and everything for the handicap access as part of the deal. Our upfront cost would be about 75 or 80,000 to get all utilities in and pay the fee to have the building set. And then we're still massaging the number because of what we need in the building for Dr. Stuckey to operate his clinic. It's gonna be around 3,500 a month. Then that's not an exact number, but that's what they're asking. 3,500 a month. And honestly, we would intend to have Dr. Gonzalez visit there and other specialties, so we could utilize that space as much as possible.
That's my question. So 2 million to put a new building there, why would we not just keep that for $3,500 a month? I mean, 3,500 is a lot. I mean, you could have that for years compared to $2 million.
And you're not wrong, Mindy.
For as much as they're down
Yeah.
there. I mean, that's just my thought process. I'm just asking.
And really with us coming to the board and saying, hey, listen, you know what is Diamondville does seem to be a very important area to these providers. They've built up this practice for a long period of time. And so we wanted to put into the budget the $2 million just to have it there.
Okay.
We can make the decision just based off of ROI that what you're recommending is actually the smarter thing to do. Okay. But
It isn't a set thing. that we
yeah,
have
so
to do the 2 million. That's my,
it's all about making sure that there's flexibility to make the decisions that we need to make.
in the future, if we decide.
That's exactly right.
Okay, I feel comfortable.
Is that
Okay,
good?
thank you. Yep.
Mr. Chair, could I add one more comment?
Mr. Hunsaker.
Thank you. Along with the specialty care, the $2 million price tag on the building that we had planned actually provides for an urgent care clinic and eventually primary care clinic, as well as the specialty care. So that building is more than twice as big as the one we'll rent to keep our presence down there. So honestly, there was some logic behind the larger building because we wanted to open urgent care and have primary care there eventually. So we wanted to get our, as much as we hear from that community down there, please bring us more services, please bring us more services. That was we anticipated doing all of those things versus just some space for Stuckey and McCord.
First of all, it's Evan, did you have your hand?
No, so if we
Clint,
do,
did I ever get back to you? Benji, go ahead first.
So if we do put an urgent care and a primary, wouldn't that be taking away from South Lincoln? If we go down there, wouldn't they be upset with us for bringing those in when South Lincoln is already there?
I'll provide an answer. They're not necessarily providing very well
Very well, right
at
now.
all, and I friends that I talk to down there are anxious to have better medical services.
They already don't like us. That's why I'm asking.
No,
because
well, but I don't.
Patients, but some of the patients, but it's.
That, you're talking to board, and my observation is, this is what's Cameron, 5,000 population? So the way we, 35. The way we treated Alpine years ago is we put in a temporary clinic and they were the redhead stepchild, in my opinion. We didn't give them really good services. Now we've got a big facility and we're giving them really good services. And I think a better president, if we're gonna go to Diamondville with our specialty and try the other, I think we ought to have something that is not a temporary trailer. I think it's an investment in the future. You got a lot of things happening in South Lincoln County, way more. I mean, we have a lot of growth, but they're gonna have, that's where the sales tax is gonna be. That's where the growth is going to be, assuming TerraPower comes in, which right now, everything seems pretty positive with that. So my observation is, and I'm a party of one, I'm sure on this one too, is that as soon as, and I would have done it before, but maybe as soon as we get the 401k back in place with our cash flow, we ought to be thinking about that particular capital asset.
That's just a question I had. Thank you.
No, and I'm gonna give you my opinion, and I think I'm a party of one on that one, so.
Thank you. I appreciate the answer.
I think that's the right financial decision to do. I don't know that South Lincoln County is going to, I don't know what they're gonna do. You're right. We've met them before. I mean, before any of this board was, were you here?
Yeah.
Well,
Cool.
he's not there anymore, right? It's not the same guy. that
No,
was here before.
No, and I know that Dan has reached out and they haven't really been willing to help, but we've met with their board and I don't think it's as bad as it sounds, but they're not allowing us to help at all. Is that fair to say, Dan?
Well, again, I don't want to speak for them. All I know is that I'm here to support our positions. And whatever we can do to help their practices have sustainability, success and sustainability in their practices, we're going to do that. Because if they're successful, Star Valley Health is successful. And that's just the name of the game. And it's very apparent that Dr. Stuckey has done everything he possibly can to engage with them. But that same sentiment that I just shared has not been reciprocated to him. And so I'm not going to pretend to read in anything. It's just, it does baffle me. And it's unfortunate that we're in this situation, but we've got to support these physicians and their practices.
Okay. Well, I have some questions on here.
Well, just to comment on that, I think that I see both sides of that. And I think that my personal opinion, I think that financially right now,
the smart decision is moving forward with the mobile trailer. I do not think, in my personal opinion, I do not think that's a long-term plan. I think that, we do a short-term plan until financially it makes sense. Just my thoughts.
Anybody else have any comments on the CEO report? Clint,
Sure.
yeah, we need to get back to you.
Couple of questions that, well, one's a comment. So on your patient communication, Dan, and this is something we're going to try to implement in our office, is if, I think it would be really good for the patients and the public sentiment of, I'm getting this bill a year late, never heard anything from it. We're going to try to implement in our office where when a claim gets denied, we're just going to do a super quick call to them. Hey, just let you know, we just got a denial. We're still working on it. Here's the charges that are still out there, just so you can take a minute and a half. They'll go a long ways. And then, Dan, what would you have for us? And I'm just using the number 3. So let's just use the number 3. It could be 2, it could be 4. What 3 metrics can we watch that show that you're that we're moving in a positive direction in this revenue cycle? And what's one of those? Is there one that we could point to that shows that we got a really good patient satisfaction in that area, that the community is now the big rubbing spot and the big hatred towards the hospital is the rev cycle?
Mhm.
What metrics could we use to go, hey, we are going in the correct direction? In fact, hospitals are calling us going, man, Dan,
Yeah.
how'd you do it?
Yeah. I think it's a great question. And, I'll throw out some metrics. I don't know if we'll end up settling on these. But the first one is obviously days in accounts receivable. We know that where we are in the 70s is not sustainable. It's not healthy. And there's various reasons why we got there, especially with the EMR conversion combined with the cybersecurity attack. But as we noted, in just a matter of a month, we brought that down to 10 days. So we're heading in the right direction. So that's number 1. Number 2, as far as patient satisfaction, we can work with our survey team from Press-Ganey to actually have a specific question around their billing experience. And we can measure that. I don't know if that's currently on the survey. Right now, there are surveys that go out for the clinics. There are surveys that go out for the emergency room, surveys that go out for inpatient stays, the OR. What am I missing?
Physical therapy.
Physical therapy. So we would probably have to incorporate that question on each one of those different surveys. And then the last one that I would say is very important is that we see our days cash on hand go up significantly. I think the days cash on hand right now is where we want that to get that into a zone where we feel like we can handle more of the challenges that we foresee are going to happen to our independent hospital. If you want to be independent, you've got to have a days cash on hand number that is significant. Now we have made the decision to grow. And so a lot of our cash has been used to grow where we are right now. This upcoming year, as you saw in the operating budget, is going to be still stabilization. There's not a lot that we're going to invest in big projects. We put a placeholder for the Diamond Bill, but this is all about optimizing the growth that we've already had over the last several years and getting to a spot where the revenue cycle, so the days in accounts receivable are driving down, the patient satisfaction is coming up, and the days cash on hand are at a point where we feel confident that we can invest in more growth initiatives. I think we need to spend the next 12 months doing that.
I can give you an anecdote. I had a friend of mine that said they were having a couple of procedures here and said, hey, we met with a financial counselor right up front. This is really nice. And so, I think it's starting. I'm not saying that it's 100%. I'm just saying that's the first time I've heard that they outlined what the costs were going to be, what the deductibles were, everything else, and they had a good experience with that. And we still need to refine it. Question.
So I'll ask you, and then you can ask who it needs to be. This trust anything, when could that get added and when could we have a number to look at as a board?
I think Dan would know that better than I.
Well, it takes money. Like they don't do anything for free. So
Right.
if we're gonna add the questions, all we have to do is have the conversation with them, pay the money, and then they can add the questions. So I think we could probably just to be, give ourselves a little bit of buffer. Hopefully we can start that in July.
I don't want to be responsible for taking the day's cash on hand down because of my.
You won't.
So if
It won't be
it's
that.
financially responsible, that would be a great metric to look at. Otherwise, blank hole.
And we want to be in a place where we think we're doing it the way we want to do it.
Let's have Andy is waiting.
Chairman, so, Dan, so Dave's question on hand, you said, what number are you trying to get to feel comfortable? I guess that's, where's your guys' goal to feel comfortable is mine.
Well, so there's two trains of thought here, right? One, the information that we're receiving from First Bank, they have many hospital clients in their portfolio. And our original 100 days cash on hand, they're seeing from their portfolio of hospital, customers, is that those hospitals are getting the squeeze on that covenant as well. And so there's conversations about lowering that days cash on hand. So from a banking standpoint and solvency and, feeling comfortable with the health of the business, that there's that banking vantage point, right? That's that one perspective. Our perspective is, if we really want to get serious about us being independent, we have to fill the coffers of our investment funds. And and it's going to be difficult to do that when there are so many headwinds on the industry right now. But if we feel like we've gotten enough scale with our growth that we can generate the cash to do that. Do I have a specific days cash on hand number that I would like to get to? Well, there are facilities that are 500 days cash on hand. There's some that are 600 days.
We need to talk. I'm not sure I like that.
Okay, so then the third perspective is, what are you doing with that cash? Just sitting on it, right?
That's right.
And how do you answer to the public that, okay, so
You're not charging too much.
well, exactly, or there's
Or missing opportunities.
or missing opportunities. So there's going to always be a vantage point depending on your paradigm of how to best use that cash. I'm just saying that knowing the conservative nature of the Valley and Western Wyoming, we have used debt, which I think has been the right decision to grow and be aggressive there. But I think that in order for us to take on more debt, we're going to have to show that the financial situation is in line with some of the best performing hospitals in the country.
And where,
Jerry, if I may, in Wyoming, which is our neck of the woods, right? There's only very few independent small hospitals that come close to 100 days. There's just a couple that are kind of comparable to us. So I think, Dan, you're right. We have my minute run in my mind is 80, but pushing 100, but not having to, it's going up in a trend. So the term sheet that was given to us early on, we were to add, another facility, etc., was 80. But I'd rather be north in the 3-digit area that would prove that we could weather a shake in the storm, what a big windstorm, we can weather it. But the other comment is that our days in receivable today is increasing very well and getting really good from, it's not perfect, but it's from where we came from the payers. The piece it's the stronger anchor.
Increasing or increasing?
No, it's increasing in performance. So if you just look at the DSO, say we're at 70 days.
Day sales outstanding or days in accounts receivable.
We're about 20, we're about 57 from just insurance companies. The other 20 is from patients. And with revenue enterprises, they believe they can get that down over time, not years, over time to where 120-day patient count is a rarity. That's where they're going. At least we talked to Doug Dunbar the other day. That's a big opportunity. And if we continue to improve with the payers, we can get patient bill out faster. That's what's holding the patient's bill, timely billing, is we can't bill them until we're settled with insurance. So they're kind of joined at the hip. Patients say, I've got my bill for 5 months, so that's how long it's been taking to settle your claim. They don't understand there's a link there. We can't, Epic wouldn't even allow us to bill before we have an insurance settle. So they're kind of hand in hand there.
So that's definitely coming down. I don't know whether I've probably told some of you, another anecdote. I got a bill from a different provider than the hospital, this month. And, they said, sorry, this is a little late. And I looked at it and my wife had visited them in June of 24. And they finally got the insurance settled and sent me a bill. And I was thinking, thanks. We're not the only ones. Maybe there's others in the medical profession that are having the same problem. Anyway, any other questions over here? Cool.
Okay, so just a couple comments. Days cash on hand, as a metric, it's going to be affected directly by your days of receivables, right? But at the same time, when you're talking, hey, I'm comfortable with 80 days cash on hand, you have to plan so that if you have another fiscal year 2024, you're still above 80. You can't say, hey, we're getting above 80, everything's great. You have to plan for the worst case scenario. And so I don't know the number. I mean, that's something that we'll leave it to admin to come up with, but I'm just saying we can't say, so if we want to be at 80, you can't plan to be at 80 and just skip along. You gotta put your days cash on hand up. And especially when we're talking about potential growth opportunities down the road, we should have enough cash on hand to be able to fund some of those investments if we wanted to. Maybe not fund them fully, but fund a portion of it. We shouldn't have to go to external debt to grow all the time. We should be able to fund a portion of it internally. And so there's again, your days cash on hand may climb and then it may fluctuate down.
Yeah,
Right.
when it hits a threshold,
Right. And
300 in cash, and then we make a CapEx.
yeah, whatever it is, but just real quick, I also want to touch on, so Dan had talked about and mentioned that, hey, mid-70s and days in receivables is too high. Yeah, I 100% agree. The only thing I was going to note though, and I just, for everybody's knowledge, is we were in the mid-70s way back in prior to Scott getting here, prior to, I'm not even sure if it was right about the time that Dan came in. We had grown to the mid-70s in AR. So this is just something that's been going on for quite some time. And it's something that we're addressing some overall process changes that are impacting us from things that were far prior to the electronic medical record system and or change and the Change Healthcare Act too. I mean, so it's an ongoing issue, something that's been going on for longer than just the recent stuff. So anyway, that's my comments, Mr. Chair.
Any other comments? Yeah.
Just briefly, I appreciate the conversation around the key metrics looking forward, but I also try to give credit where it's due. Dan, I thank you for your CEO report. I feel like a couple of months ago when we started this, you set out with a plan, and while there's still a bit of work, you represented that you're making some great progress on that plan, and I know that some credit goes to you, but I know a lot of it goes to your team members as well, and I just commend you for the progress that you're making thus far, restoring the employee matching on their retirement is critical, I think, but there's other metrics here that I think are just really positive, and just I want to commend you and your admin team for the progress that's being made there. Thank you. Thank you, Chair.
Did I see a hand, Abby?
Yeah, I'm hesitant because I don't know that it fits in here, but we've been talking about it and touching on it, but we tentatively approved CapEx expenditures. We're talking about where we're getting financially, and a concern that I want to bring up, especially since it's recorded, is to stay. We're talking about maybe 2 million for a camera building and $500,000 helipad. And my concern is that we put it under the guise of we need to plan for growth, but we know that that's not going to happen in the first year. And we're talking about reasonable, but $70,000 for electrical, which isn't wasted. The utilities, it's not a wasted expense. I feel good about spending that, putting a modular on. If I spent that kind of money, I would have to plan for myself that that's the facility I was using for at least a year. So my question is, why are we tentatively throwing these CapEx for growth in there when that decision, that $70,000 buy-in should buy us a year's time? Can we talk about moving that to 2026 so that in good conscience, when we're kind of.
So that's not a final budget.
I
I think
know
that's a
that.
discussion for next month.
But I put
for us to
plans
think
in,
about.
somebody's like, why'd you approve that budget? And I'm like, it's been grating on me, so I'm like, I just have to
Well,
put it out
we
there.
we haven't approved it yet.
I agree.
All we've done is we're sending it to the state as our preliminary. In June, we will approve a final cap budget and operating budget. We've already approved a strategic plan, I think, earlier in the year.
Yeah.
And so those are the two final things we need to do. So I'm not disagreeing that we ought to have some more discussion. I'd like to think about it. Your thoughts,
Mr. Chair.
where those go?
Mr. Chair,
Yes, Dan.
maybe I can alleviate some of the concerns that Abby's might be feeling. So there's two parts to the capital budget. There's the routine part, which,
I understand that.
yeah, but the special projects, that have a certain amount that, these sizable investments. I think that those, it's really a placeholder that this is what we're
shooting for.
This is what we're shooting for, but there is going to be a robust discussion on what really is the right decision for any of these special projects. So look at it just as a placeholder. With this thing is not going to move forward until there is a robust discussion on, is that the right decision?
Does that help?
It's helpful.
I think that's kind of what we've done on a number of items is we've.
It's nice to know what's on their mind going forward, but it's also always about robust leases on things or testing the parameters of it, getting the numbers like.
Yeah, and I think we've always had good, robust discussions about any of these large deals, and we've vetted them out, and so I think that will still happen. I don't think putting in the CapEx, we can put those parameters on it and say, you got to come back and prove to us this is really what we need to do and when. But we can have it as a placeholder. Mike.
Mr. Chair, if I may, just to add a little bit more backdrop to the Diamondville thing. If the board remembers, we have invested about $60,000 in engineering in that 4,200 square foot modular building. We do have a placeholder for the manufacturing of that in place, but that's not until March of 2026. That's when we're in line for them to build it for us. And that can be moved if we need to move it again and to a future date.
Earlier or later?
Later, not earlier, but later. Because move it to a later date. So timing wise, I think there really weren't any plans. If everything went appropriately and there were funds available, that building wouldn't be in place until July or August of 26 anyway. So that's just a timing thing. And if we moved it back a few months into the next fiscal year, not gonna be the death of anything. It would just be a timing thing we'd need to adjust.
So because you're saying, what I'm hearing you say is because of the pause that we put on these before this all happened, I thought we were planning this fall to be in that building. Why?
No,
Forgetting that?
it was going to be next spring anyway.
Oh,
They were gonna, no, I'm sorry.
No,
We've done this so many times.
I was thinking we were gonna get it ordered,
We were gonna be available in September this year, then we moved it to later.
then we paused.
Now-
So
now
right
we
now,
paused.
it's next spring at the earliest because we're in the assembly line or the queue. And and we can always.
Remember, we do have
change
some
that.
engineering costs that we've sunk
Yep.
into that building.
But that's part of that 350 to 60,000, or is that, yeah, right? Other questions? We deviated. Anybody have any final questions? I have one. I just recapping on assignments. Trevor EMS, I'd love to hear the answers for the questions that were asked us and formulate something that can be sent to her. The other one I'd like, and I did get some preliminary information from Scott, but I'd like, I don't know how we do this, Dan. One of the things that came out of the public meeting that struck me and still helped me is you're too expensive. And I know we've made some, I mean, a couple of years ago or a year ago, we did RMS. We did some where we have to increase both volumes and rate. And over the years, back before you were here, I know we just took a straight 3 or 4% sometimes. One year we didn't do it. So then the next year we realized we had to make up for it. I think, Mike, and we went like an 8%. And so, our rates going up and the inflationary costs. And I guess what I'm wondering, and I know we can go off Charge Master, Scott and I talked about, and they did some sampling of various Charge Masters in the region. But our last discussion is Charge Master doesn't mean anything. It's the rates they post. It's not necessarily the rates they pay, but so how do we figure out if we're really as expensive as the public think we are? Is there a way to do that? Can we get our own basket of goods put together? I mean, I don't know. I'm not an economist that much, but I would like to know, and let me just finish, Dan, for you. In the past, during the years I've been on the board, we had the Southeast Idaho Association would put out a pamphlet or something, a comparison sheet of procedures. Wasn't everything, they just picked them, and the philosophy of the board at that time, and we may want to be different as this board, is we wanted to be not the high and the low, but we were somewhere in the middle, medium. And we compared ourselves in Wyoming Hospital Association. I don't think we participated with them. They had a survey, didn't they, Mike? But we weren't participating, so we couldn't get their data. It's always kind of frustrating me. Anyway, is there a way we can have some comparisons of, and I don't know, I'm not thinking of big procedures, orthopedics and that. I'm thinking that the things that happen 80% of the time, I'm told people go, I mean, if they go to an urgent care clinic, 80 to 90% of their AOs can be taken care of. And so that's where people are going to be in family practice, urgent care, and then radiology of some kind. I don't know what we check, and Scott has given me something, but I'm wondering, is Charge Master the only thing we can compare to? And does that really give us the correct information that we're not the most expensive? We had the economic study, and I need to clarify on the economic study because I've heard some that we're the most expensive hospital in Wyoming. That is not what the economic study said. It said that medical in Afton grew, and it's the most expensive in the state of Wyoming. But it's not just our hospital in that category. That basket of goods, which I think Mike checked out, was a number of medical things. Not only medical supplies, but
other dentists, eye doctors, everybody else, wasn't just the hospital. So I don't think we can blankly say that we're the most expensive hospital in the state of Wyoming. I think that's a false fact. But I'd like to find out what the truth is. I don't know how we do that. That was a long question, and you'll have a short answer, I'm sure.
Yeah. So I took some time during a town hall meeting to address this expensive definition. And just in summary, you can compare charges for any item, any facility, anywhere, because it's mandated by federal law.
That's the charge code.
That's the charge
on the website.
What I tried to help the public understand that has nothing to do with how expensive a facility is. There's two things that determine whether or not you're more expensive than another facility. And it comes down to two contracts that are not available. One, every single patient that has insurance, there's a contract between the insurance company and their employer. That determines deductible, that determines co-insurance rates, that determines co-pays. It drives what a patient is responsible for based off of the contract that was negotiated between the insurance company, the carrier, and their employer. Then you have to match that up with the contract that has been negotiated between the provider and the insurance company. That's not known. So we can sit here for hours and hours and compare MRIs and surgeries and primary care visits and all the different codes, the thousands and thousands of codes, and you're going to come to the conclusion, based off of that analysis, that our charges in some cases are higher. Our charges in some cases are right in line with other facilities, and our charges are below some facilities. But it's never going to give you the definition of whether or not we are more expensive. So let me add this point. Now, because of the methodology that we have with our managed care contracts, there are managed care contracts that are referred to as a percent of charges. So if we do increase our charges, the one area where our patients might have to pay more out of pocket is once their co-insurance kicks in. I'm looking into how we can alleviate that for our patients. So that if our charges do go up, or if we are charging more than maybe some other hospital, that their out-of-pocket expense can be minimized.
Okay.
So what does it depend on? Well, for every patient, depending on their insurance, depending on their deductible, their co-insurance, that truly is the expensive definition for the patient. So I'm just going to take Abby, for example. Abby, you don't mind me sharing,
You're welcome to share.
through her insurance, she's part of the Church of Jesus Christ of Latter-day Saints health insurance program. And they don't, for those folks that live outside of the Salt Lake Valley, they use United Healthcare as the carrier to determine her responsibility, financial responsibility. Blue Cross Blue Shield here locally for a physician is not, so United Healthcare is on a percent of charges. Blue Cross Blue Shield here locally for physicians is on a fee schedule. It's not percent of charges. So when you try to have a conversation with Abby about how expensive her care is just to see a physician, it is going to be significantly different than somebody that uses Blue Cross Blue Shield. And so having an apples to apples comparison, it's impossible. Unless the industry says that every contract between employers and insurance carriers are made public. And every
Public records?
and every contract between providers and insurance companies are also made public.
So those aren't public records that we
No.
can ask for, huh? All right. So my question, my other question then is, we're looking at service lines, and we had a company with United Healthcare, I think, it wasn't Optum, it was somebody else, or was a part of Optum, right? And they did a bunch of research to say we're losing
Market share.
and things like that. Do they not have the same data for pricing?
Well, they can, like any other company, they can just go ahead and look at charges.
Well, I know,
But
but
that
you just told me that doesn't work.
Well, that's what I'm saying to you. That's what I'm saying to you is we can have, we can charge $50,000 more than St. John's, for example, on a particular item. But that really isn't going to determine how expensive it is to the patient.
So, these surveys that we used to get, are those, I mean, that was before we had charge codes.
No, it was just charges. There's no way. The only thing that they would compare is that they, I mean, I guess you could share what you're getting reimbursed.
Do you remember what those were based on, Mike? Those surveys?
It wasn't reimbursed. Was it reimbursement from the providers of what they were getting for a?
No, it was charges.
It was charges.
So it was, then there was no charge master at the time or requirement, but you're saying that's what they used? So we may not have known what we were really comparing against, is what you're telling me.
I think that's true.
What a stupid business. I mean, I just gotta tell you, it sounds like,
It's not survey.
it sounds like insurance companies, because I can never get an apples to apples quote on anything. They always throw something extra in. Anyway, okay, so we really can't ever figure out if we're more expensive.
Well, we will be more than willing to show all of the comparisons. So we just did this recently. We took St. John's, we took ERMAC, we took the University of Utah and Star Valley Health. We can, just for the sake of time. And we looked at inpatients, we looked at primary care, we looked at radiology, we looked at lab. And we can show you where we're high, where we're low on charges. It's not going to solve the problem when it comes to the definition of expensive.
That's what I wanted to discuss on that. You might want to send this out to board members, Scott. I mean, he provided this, it's a spreadsheet on what Dan just talked about. This is, they called around to the various hospitals, ERMAC, St. John's, U of U, got an average, and Star Valley Health, our percentage of the average, whether we're high or low. And some were just like at 105% of average, others were at 48% of average. I mean, I don't know whether this is any good, but they went ahead and did it, and if that's the best we can do, I guess send it out to the board members, they can use it for what they want to, but
If I may, Chair?
yes.
I mean, some of our issues in the past 18 months has been not on purpose, but giving a patient the wrong number.
Right, the charge code?
Yeah, not the charge code.
Oh.
It's just, it's our tools that are, I would say, I need an estimate.
But yeah,
It's been wrong. And
Yeah.
if it's wrong once, it just spreads like wildfire, because it's like, it could be, order of magnitude and be wrong, like, oops. But it gets back like, how in the world, And if you drill back into most of these, it's our oops. And that coupled with continue to educate our patients about how insurance works. I think that's about all we can do to prove to them that it's a fair deal. And just minimize some of the, the tools we had in Epic they got a lot better now.
Yeah.
Right? But I agree, Dan, if we make one little oops, it can spread.
Well, yeah, we've got it
We're
correct.
getting better, but we still have communication to do our.
This is worse than banks.
Banks are straightforward. They tell you what it's gonna be,
Threw me under the bus.
and we can't. At least they tell you what it is up front. Yes, Avenue.
So to that point, I do think that is the crux of the problem. That is patient satisfaction would be highly dependent on knowing what the bottom line would be before kind of talking to you, but I'm not really needing to. What resources do you have to effectively allocate through that process? I know Dr. Hauser's been doing that a little bit more than some of the other areas. That's true, right?
Actually, did a pretty darn good job.
So we're calling financial counselors. They're in charge of like all specialties around the whole hospital. Meaning,
Trying to make an estimate, yeah.
yeah. So they don't necessarily like work with the surgeons in the OR and then like, you know, they made their assessment and then it gets handed into the financial counselor. Like, can you kind of just tell me what that process was looking like?
Well, they sit with the patient, or they hope to talk to them face to face or live. And they understand the procedure, and then Epic provides an estimate.
Based on their insurance. Or is it still kind of general? Yeah.
Yeah, but they're getting pretty good shine.
So when you say financial counselor, how many are there? That's the issue. I mean, we all agree. That's a challenge.
All right, we don't need to beat this dead horse. Mr. Very long. Yes, Cole, you had a last comment?
One comment. You guys have heard this from me before, but we were talking about measuring our, let's say, reputation within the community pertaining to the red cycle. I personally think that this is one of the most important parts of that, because if a lot of these people, you know, they're judging their hospital experience on a hospital visit from 6 months ago because they haven't been since, or a year ago, because they haven't been to the hospital since then. There's been a lot of changes, but they don't know that. They haven't experienced that. So in my mind, a lot of cases, we have one chance to get it right and do right by the patient. And that's going to be their experience for the next year or however long until they come back again. And so just a comment, I think this is one of the, you know, when we talk about measuring, you know, satisfaction, patient satisfaction, and this is going to be a major part of it. I really believe.
Well, I think we've got to get our staff educated so that we're moving always forward instead of sometimes it's one step forward and two step back. And to shoot ourselves in the foot is what I hear from the community. And it's mistake, and it's fine. We all make mistakes. I mean, I make them. And I don't know how to change it in this industry, but I know we're headed in the right direction. So I'm comfortable with that. Anybody have a word? Anything else, Mike?
One very short comment.
Please.
I've had the opportunity to work with Scott and his team recently. And when you say revenue cycle, I think sometimes we just think, oh, it's the financial counselor and the billers. Revenue cycle starts when the patient walks in the clinic and checks in. And it ends when Scott puts the money in the bank. And that is a long, drawn out, complicated process. It touches nearly every department in this hospital. And so it's really hard to pigeonhole that with one group of people.
Agreed.
And I want you to know our billers and our financial counselors and our coders are really taking this personally as a challenge to improve. That's just one part of it. Jeremy's team, Tori's team are all involved in this process, and it's got to be like a well orchestrated dance. It really has to be. And those are some of the things we're working on right now, is that process improvement. So financial counselor knows when they need to call the person and let them know what their financial responsibility is, and a million other things to get that patient the care they need. So I just wanted to share that.
No, I appreciate it. I think we're ready to go into executive session. Oh, Cole.
Can I make one?
Yeah, I've never shut anybody down.
I know, just to Mike's point, I think one key there is it needs to be a team effort overall, which means that we need to make sure that departments are willing to work with other departments. Right? I mean,
an outside take look.
And I can say that that has improved by leaps and bounds over the last time.
Yeah, I think that's huge. Good. That's good to hear. Last comment, Abby?
Yeah, sure.
Next to
Starting off
last.
with that. Yeah, this is it. The
I'll
team,
take
the
any
team
more.
comment, because you guys mentioned there were 2 financial counselors. If I was working with Dr. Cowan and I knew that the patient needed a surgery and I was a nurse for him, that's something I would want to take on to follow that financial process. What do I need Dr. Cowan to type in his notes? Do I have all the right information? I feel like we could have a lot more people rather than just 2. I mean,
We
I see that way, right?
More people involved in the process, but they're just
To the
financial
finance,
counselors that communicate with the patient.
And-
everybody preps that information so the financial counsel can actually do it.
And by the way,
It's all hands on deck.
another anecdote is I happen to have met one of the financial counselors this last week, and she did a wonderful job explaining something to one of my employees that was having a frustrating experience with our hospital. And turned out really well. I hope that they're treating everybody that walks in there and that you don't have to be a board member to go there and get special treatment. I hope it wasn't special treatment. I didn't think it was. But anyway, I think we're headed in the right direction from little things that I've seen and experienced here lately. So with that said, anybody else have any last comments? Questions? All right, we're ready to go into executive session. We are going to dismiss everybody except Mike and Dan and the board and our attorneys. And I think Andrew's staying here.
I make a motion that we move into executive
And
session
what do we need to talk about?
for the purposes of personnel, litigation, and litigation. No.
Land?
For the purpose of personnel and litigation.
Do we have any other items? Let's throw real estate in there. Let's second.
I did.
Thank you, everybody, for coming.
Thank you.
Thank you.
We hope you enjoyed your experience. And I wish more would stay. Anyway. Yeah, let's take, everybody okay with a 5-minute break? We're this long.
That's not a motion inside executive.
Yeah, let's take a 5-minute recess before we go into executive.
I make a motion that we drag this meeting.
Well, and then the issue right now, that
I'm gonna make a motion that we sign for this meeting. Decide we need to wrap it up quicker.
is.
Or